Okay, so the health assessment is part of the foundation of the nursing process. Without the health assessment, we're not going to be able to get to all the other parts of that nursing process because we won't have any information. It enables the nurse to form a nursing diagnosis and a plan of care for the patient. It establishes a frame of reference at the beginning of each shift for that nursing health assessment. So we know how stable our patient is at the very beginning of the assessment, of the shift, when we do that physical assessment. So then we can watch them throughout the day and determine if things are improving or if the patient is declining. And then it is also a holistic collection of information about the factors that affect or are affected by one's level of health. The purpose is it is an accurate health assessment will be able to provide the foundation for therapeutic nursing care. It sets, everybody else's shift, sets the stage for them to be able to care for the patient too. You admit the patient, you get all that information in, you document your assessments, and then anybody else can go back and see what's been done. And that way they can all contribute to that therapeutic nursing care. It aids in early identification of health alterations and early treatment. You evaluate your outcomes of care, and then it is a head-to-toe evaluation process. All right. So this is just a little follow-up of what we said before. Another name for that focused assessment, you might hear people say that it's episodic. So you'll hear those two used interchangeably. So when we're gathering that health history, we're looking at biographical data. We are looking for the reason for the patient, for the reason that they're actually seeking health care. We want to know their chief complaint. So this is the current reason why they're seeking care. We want to ask questions so that we can discover exactly what the patient thinks their health problem is that needs to be treated. We always want to record that information in the client's own words. So for example, if your patient said, I had terrible pain in my right side after I ate lunch, I've never had pain this bad, you would document that in your, wherever you could document that in a note, in your progress note, and you would put it in quotes. So that's the patient's chief complaint. We want to know any of their past medical history. So any childhood diseases they may have had, any physical injuries, if they've had major illnesses, even psychiatric issues, hospitalizations, if they've had any surgical procedures, if they've had any use of drugs or alcohol, and then of course, any allergies. So this is important to get all this information because it's going to help us formulate their plan of care, and then it's going to help identify things that may affect their current care. Let's see, family history. We always want to know about family history. Usually first term and like mom and dad and grandparents and sisters and brothers. We want to know if they're living or they're deceased, how long they lived and what their cause of death was. That's helpful, especially for genetic diseases like breast cancer and colon cancer, things like that. You can determine how at risk your patient is based upon the information that they give you. The functional health. So this is how well the client can manage activities of daily living. So this is really important, especially with this older population. You always want to talk to them and find out, who do you live at home with? If you have a patient that's on oxygen and you want to think, they're going to go home on oxygen. Well, tell me a little bit more about your living situation. Or do you have a house that has more than one floor? Do you have a lot of steps to get into the house? These are things that you want to think about because you want to be able to make sure that they have all the services that they need when they go home. If they can't walk long distances or they have trouble bathing and toileting, well, how are they going to be able to do that when they get home if they don't have a good support network? Maybe they need to go to subacute rehab for a little bit before they can go home because you don't want them to go home and get hurt and then be readmitted back into the hospital again. So then any cultural or psychosocial issues, primary language, any religious or cultural needs that they may have, that kind of stuff. review of the body. So review of systems. So this is actually just a review of body systems. So this is when the nurse just asks questions about each body system to help try and trigger a client's memory of things that maybe they overlooked. Especially again, in that older population, they are not always the best historians because they're older and they forget. And sometimes when you ask about things, because I'll say, you know, are you having any symptoms today? Is anything going on? No, I feel great. And then I'll know that they have diabetes. So then I'll say, well, do you have any numbness or tingling in your hands or feet? Oh yeah, I do have some of that. So ask those questions about each system to get them to give you more information. And then any lifestyle or health practices. So, you know, any social activities, do they work out? Are they healthy? Do they, you know, exercise 3 or 4 times a week? Kind of get that information about, you know, where do they work? What kind of stress levels they have? So that way you can educate them about certain things when they go home. All right, so when we look at their past health history, we say we want to look at those childhood diseases, any previous injuries or accidents, any severe or serious or chronic injuries. Allergies, of course, are really, really important. So immunizations, I always ask them, have you had a flu vaccine this year if it's flu season? And have you had a pneumonia vaccine? So knowing what your, where your patient is with regards to what immunizations they need. So you know that older population, 50 and older, did they get the shingles vaccine? Have you gotten your pneumonia vaccine? Are you getting a flu vaccine? And now, of course, this COVID vaccine. We want to make sure that our older population is taking advantage of those because they're at big risk for developing those issues. And then we said that family history, that's important too. So the lifestyle functional assessment. So this assessment is important because it helps us determine how the client deals with his or her own health in terms of what kind of nutrition they have, do they exercise, do they take medications every day, what's their sleep and their rest like, how they engage in self-care activities and such, you know, things like that. We want to get information from them by using those open-ended questions. We've talked about that before. We want to limit those questions that are just going to allow them to give us a yes or no response. We want them to give us as much information as they can. So we want to talk about coping and stress. We talked about that. Interpersonal relationships. You know, are they dating anyone? Do they have someone at home to take care of them? Do they live alone? What kind of jobs do they do? Are they at risk for any, like, you know, maybe you have a person who's a new diabetic and you're trying to regulate their blood sugar, and you would maybe want to inquire more about where they work and what they do. So if your patient is a truck driver, that could be an issue because they are just learning how to regulate their blood sugar and they drive for a living. And if they're not completely educated about when to check it, what to eat, how to handle low blood sugar, how to recognize the signs and symptoms, that could be a huge problem. Their blood sugar could drop, they could pass out behind the wheel, they could kill themselves, they could kill somebody else. So really looking at that lifestyle and that functional assessment is very important. So this ADL assessment, this is very, very important, especially for your older patients. Can they answer the phone? Can they make phone calls? That's important because especially if they're living alone, you want to know that they're able to get help if they need help. How weak are they? Can they open jars? Do you think that they have the ability to sit in front of the sink and, you know, wash themselves every day? Do you think that they can cook for themselves? Do you think that they can feed themselves? Are they able to safely get themselves dressed? These are all things you're going to want to look at for your patient because you're going to want to advocate for them and make sure that they go to rehab if they need to, or that they have someone that's going to come to the home and visit them after they go home so that they can get better and not be readmitted again into the hospital. Our older population is so vulnerable, so it's really important we look out for them. So then we have nonverbal behaviors. So we talked about this before. You know, you might go into your room and say, hi, Mrs. Jones, how are you feeling? And her head's down and she's not making eye contact. And she was like, I'm fine, not giving you any information. Maybe she's slumped over in the bed or she's guarding her stomach. So what she tells you might be completely different from what you're getting based upon her nonverbal behaviors. So positive behaviors would be if the patient was very relaxed, if they had an open posture, leaning slightly towards the person is a positive when they're talking to you. If they speak at a moderate rate of speech, this goes for you too, so it's for you and the patient. Appropriate touch, appropriate eye contact. Negative behaviors would be if you are sitting with a tense posture or your patient is. If you're slouched over, it kind of gives the impression that you don't really care. The same thing with the patient. If they're slouched over, not paying attention to you, they're not really engaged in what you're asking them. You might not get the appropriate information. This is more so for you guys. Well, talking too fast or talking too slow can be overwhelming for some patients. Moving around, avoiding eye contact, focusing on notes, or the patient doing the same thing. Moving around in the bed, not making eye contact, and then too frequent or inappropriate touch. So some patients don't like to be touched. Some of your patients are very touchy. They like to hold your hand. They want to hold your hand. That's how they show appreciation. Nurses are not always fans of being touched, and that's perfectly fine. It's okay if you tell your patient that. There's no, it doesn't say anywhere that when you're a nurse that you have to allow your patients to touch you or that you have to touch them more than you need to. You have to be comfortable with whatever is good for you. So when you're doing that interview, they want you to avoid these 10 traps. So providing false reassurance. I struggle with this one myself, especially when patients are sick or they're crying or they're upset about something. I always want to tell them that everything is going to be okay. And we can't do that because that's lying, because we don't know always that everything is going to be okay. We want to learn how to be good listeners, but we want to avoid giving unwanted advice unless they ask. So it's okay to listen, show empathy, show understanding, but make sure we're not giving advice unless they're asking us. Using our authority, we don't want to use our authority in the wrong way. We don't want to use language or body styles that are going to give them the impression that we're trying to avoid them. Engaging in distancing, so making sure we're keeping, everybody has their distance to where, sometimes it's too close, sometimes it's just right. Just try and observe what your patient is comfortable with. Use professional jargon. We want to not use professional jargon. I get confused with this slide. So I say that you speak in professional terms, but you also have to take into consideration the educational level of your patient. So if you're saying things and you feel like your patient doesn't understand, it's okay for you to verify, do you understand what I'm saying? Does that make sense? Do you need me to explain it another way? Using leading or biased questions. We want to avoid talking too much. That's probably my problem. I talk a lot to my patients. We don't want to interrupt when we are talking to them. We want to be good listeners. And then we don't want to use the why question, because some patients find that offensive. So considerations when performing the health assessment, we want to take those lifespan considerations. So, the babies and the older people, you want to make sure you're looking at their growth and their developmental patterns, because they vary a great deal between infants and adolescents and then those older adults. We want to be culturally considerate of our patients and be sensitive of their needs. We want to try and be familiar with general cultural beliefs and how they affect the care that we provide. Examine your biases again, remain non-judgmental when you're providing care. Patient preparation, you want to explain what you're going to do. Always before you do it, tell the patient what you're going to do and make sure that it's okay. If they're going to go for...
Ryan got kicked out.
Okay, thank you. Always tell them what you're going to do. Always tell them when they're going for tests. I hear patients all the time, transporter come to the room and pick them up and they'll say, Mrs. Jones, I'm here to get you. And she'll say, I'm not going anywhere. Oh yeah, your nurse didn't tell you you're going for a test. So always make sure that they know what the plan is because it does involve them. They're the patient. So make sure you keep them prepared. Then environmental preparations. So we want to maintain their respect and privacy. So this is essentially their hospital room is essentially their home for the next couple of days while they're there. So we do have to go in and out, but make sure we're knocking on the door, asking it's okay if we come in, respect their privacy when they're in the bathroom, when they ask, to come back, give them a couple minutes. Make sure that when we're doing that physical assessment or we're bathing them or doing anything that exposes any of their private areas of their body, we want to make sure that it's a private area with the door shut or the curtain drawn. If the patient wants to finish their breakfast, and that eating has been an issue for them, you can choose to come back, let them finish their breakfast, go see another patient. So try and be accommodating if you can. We can't always, but we always try to when we can. So preparing the patient for the physical assessment. So we want to consider the physiologic and the psychological needs of the patient. So determining if your patient's going to be able to even participate in this exam. Are they a heavy patient and they're not moving because they're really, really sick? Maybe you're going to need to have a tech come in with you so that you can roll the patient together so that you can get a really good look of their skin on the back and you can listen to those lung sounds. Explain exactly what you're doing to the patient. So when I go see my patients, I come in and they know who I am when I come to do meds because I've seen them at shift change. And then I'll say, hi, I'm here to do your medications. And then I say, I'm going to do your medications. And then after that, I'm going to do a physical assessment. Is that okay? I've never really had a patient tell me no, that it's not okay. So after I give them their medications, then I tell them exactly what I'm going to do. I'm going to listen to your heart and your lung sounds in the front and in your abdomen. And then I'm going to ask you to sit up and listen to your lung sounds in the back so they know exactly what I'm doing. If you want to explain to the patient that physical assessments will not be painful, decrease patient fear and anxiety. Most patients don't think that they're painful unless it is. So sometimes if you work on a surgical unit and you have had a patient that had a hip replacement or a shoulder replacement, and you're telling them that you're going to check their strength, well, they may be a little bit apprehensive because they don't want to move their shoulder or their hip because they just had surgery. So you just would want to reassure them. Explain each procedure in detail as it's conducted. So if you're giving a Foley, you want to make sure you're keeping that patient up to date with every step that you do until you're completely done the procedure. Ask the patient to change into a gown and empty their bladder because you want them to be able to participate with the physical assessment. You have to practice time management as well. So you don't want to have to stay in there and have to stop your physical assessment because the patient decided they have to go to the bathroom. So while you're getting their meds together or you're doing something else in their room, you can tell them ahead of time and then they can go to the bathroom while you're doing what you have to do. And then answer patients' questions directly and honestly. Even if you don't know the answer, it's okay to say, I don't know, as long as you go and get the right answer. So agree on a time for the assessment. So the time should not interfere with meals, daily routines, or visiting hours. So I feel like that is true. For testing purposes, that's what we would always say in the real world. And I always tell you I'm going to be transparent and tell you what happens in the real world. I would never say, no, you can't eat. I have to do your physical assessment. If I have a patient that is not stable, that is very, very sick, and I have to see them first, and I say they are on 6 liters of oxygen. I've done this a couple of times with my COVID patients. Respiratory wise, they're not very stable sometimes, or they're borderline. And when I go and I see them, I want to listen to them. I need to know what their lungs sound like. So if I have a patient that says, do you mind if you just come back? I'm really tired. Or somebody was just in here and I want to eat my breakfast. And I'll say, that's completely fine. I understand, but you're really sick. I just want to, let me just listen to your lungs in the front and the back, and then I'll come back and do the rest of it later. Normally, I like to do my whole physical assessment when I'm in there because that's just part of time management. You pass your meds, you do your physical assessment, and then you know you have that checked off your list. And you always want to know the stability of your patient. So that's why you do your physical assessment after when you're giving your meds. So there is some give and take. So if your patient is not stable, you are not going to say, sure, go ahead and finish breakfast. I'll come back later, because later when you come back, they could be dead, or they can really decompensate quickly. And then you have to intervene and you're calling a rapid, or maybe it's a code at that point. And usually when you present it to them respectfully and you tell them, you know, you're showing that compromise and you're telling them the importance of why you just want to listen to them, usually they don't have a problem with it. Make sure the patient is as free of pain as possible. So again, if you are assessing that patient with the hip surgery and you're going to want them to move around in bed, so you could always say to them, I know you're in a lot of pain today. I am going to need to come in a little bit and do a head-to-toe physical assessment. I saw you had your pain medicine at 4 o'clock this morning. How about I give it to you now? And then I'll be back in an hour, and then you'll be comfortable and I can do that assessment. Prepare the examination table. There's really no examination table unless you're working in like a primary care office. Usually it's just their bed. Provide a gown and a drape. Again, not in the hospital. Well, they're in a gown and they have cover. So this would more so be for a medical office. Gather the supplies and instruments needed. So you know you're going to need to do a physical assessment. You should have a pen light and you should have your stethoscope, because you're going to want to listen to all those good sounds. And then provide a curtain or a screen if the area is open to others. If it's, you know, they're sharing a room, you provide that privacy, pull that curtain over. If they are in their own room, you just would want to shut that door, because you do have to expose certain parts of their body. So what is the equipment that we need during a physical assessment? So a thermometer and a blood pressure cuff. A scale, maybe if they're doing daily weights and you're getting those daily weights every morning, or if you first are admitting them. Usually we don't, in the hospital setting, check their weight every single day unless they're getting daily weights. If they're a CHF patient, they have a lot of edema. A measure tape and a ruler. So a metric tape, the only time we usually use those are pretty much on focused assessments when we are measuring edema or if they have a wound somewhere. So that is not something you would need every day. It would just be something you would want to get from your supply room if that was appropriate for your patient. You should always have a flashlight or a pen light. I always have a pen light with me. I don't use it every day, but I always have it in my little carrier thing that I keep on my computer. Stethoscope, have that every shift. An eye chart. We don't do that in the hospital setting. If they have issues with their eyes, we send them to the vision center. I've never, ever done a vision test on a patient. We're going to talk about it, how to do it. You might do this, you would do it in the primary care office setting, but as nurses in the hospital setting, you're not doing that. And then a tuning fork, which that's used to check the ears for hearing, and we'll talk about that. And I've never, ever seen any of that equipment or done that as a nurse. So some of the stuff we're going to talk about, you will not do if you ever work in the hospital. It's more for primary care. So the parts of the stethoscope. So when we listen to someone with a stethoscope, the nursing word is auscultation. So we would say, I'm auscultating their lung sounds. Or when I was auscultating Mrs. Jones' lung sounds, I heard advantageous, blah, blah, blah. That's how we would use that word. So that is nothing more than listening to body sounds using a stethoscope. So the bell, you can see on the picture what piece that is. This little baby, that's how I remember it, bell baby. We usually use that to listen to babies. So the bell is that's used to listen for those soft, low-pitched sounds like heart sounds. I always see them using it where I work for the infants. I've never actually used that sound. I've never used that side of the my stethoscope before, but those are the sounds that you would use it for. The diaphragm, which is that bigger part, you want to listen to high-pitched sounds like the lungs and the bowels. So here again, the diaphragm versus the bell. So this big piece right here, that's the diaphragm, and the bell, that baby piece. Okay, so baby, bell for low sounds, diaphragm for high sounds. So now we're going to begin our assessment. So what are we going to do? We're going to wash our hands, right? We always wash our hands before we do anything. We're going to explain the purpose of the assessment and what you're going to be doing. Hi, Mrs. Jones, I'm back. I'm going to do your physical assessment today. I want to take a listen to your lungs. I want to listen to your heart sounds. I want to listen to your belly sounds. And then I want to check your circulation. Provide privacy for the patient by closing the door, pulling the curtain, whatever is appropriate. So you want to always make sure when the entire time that you're performing that physical assessment that you maintain standard precautions. What are standard precautions? Somebody knows what standard precautions is. Emmy.
Gloves when you're potential contact with bodily fluid.
Right. Very good. So make sure, depending on what body part you're touching, that you use gloves if you're not comfortable. So whenever I have to touch anybody's feet, I'm better about it now, but I really hate feet and I hate to touch feet. But I feel like I've gotten better with it. Like sometimes I touch them and I don't wear gloves and then I just wash my hands. But when you take off their socks and their skin flies everywhere, it just makes me want to gag. So I always used to do their feet and wear gloves because it just grossed me out. And if it grosses you out, then you can wear gloves. It's okay for you to do that. Make sure you're going to do wipe. Somebody tell me what wipe is. Cindy. She's like, man.
It is to wash your hands, introduce yourself, provide privacy, and educate the patient on what you're about to do.
Good job. Very good, Cindy. Very good. And everything we just talked about, you might see again in your exam. So that's an important slide. So infection control. The activities used to minimize the spread of microorganisms which cause disease. Infection control concepts include skin and wounds. So a safer environment, hand hygiene. You guys are always going to hear about this. Even when you become nurses, it's going to be all over the place where you work, talking about hand hygiene. So this is the single most important step to decreasing microorganism transmission. So you're going to wash your hands before and after physical contact with each patient, after inadvertent contact with blood, body fluids, secretions, and excretions, after contact with any equipment that could be contaminated with body fluids, and then after removing your gloves. So you are going to wear gloves when the potential exists for contact with any body fluids. For example, blood, mucous membranes, body fluids, drainage, and open skin lesions. And, you know, sometimes I told you, I think I said this before, you go in and you don't think that your patient has anything coming out from anywhere, but then you pull the covers back and there's surprises under there for you. So maybe they peed, maybe they pooped. And then if you just put your hands in there, then you're going to get it on your hands. So it's okay to wear gloves. It's always good to protect yourself. Wearing gloves is not a protective substitute to washing hands. And then you would want to wear a gown, a mask, and protective eyewear when the potential exists for any blood or body fluid splattering. So positions that can be used when we perform a physical assessment. So your patient can be standing. When they're standing, we're going to be looking at their posture, right? Do they stand straight up? Do they lean over to the one side? Is their is their back really hunched? Are they, hunched over towards the front? What's their balance like? Are they able to stand up well? Do they wobble? Do they have to hold onto the bed? When they're ambulating in the room, do they move very fluidly, put one foot in front of the other with no issues? Do they wobble? Are they having problems with one leg? Things like that. Sitting, this allows you to visualize the upper body. think everybody knows what the sitting position is. And then we have supine. So this allows relaxation of those abdominal muscles. And then that prone assessment, you could use that for assessment of the hip joint and the posterior thorax. We have the Sims lateral. So this is the position that you would use if you are doing an assessment of the rectum or the vagina. You would also use this position if you're giving enemas and suppositories. This is the position that you would give them in. Then you have the knee chest. So that's for assessment of the anus and rectum. And I've never, ever done an assessment in that position. That is probably a more a focused assessment for a certain field. I've never done that as a nurse. You have the dorsal recumbent, which is used for patients that are having difficulty maintaining the supine position. So you would use this for your patients who are getting Foley's, if you were cleaning them up, things like that. And then your lithotomy, which is the assessment of the female genitalia and rectum. So tools of the physical assessment. So those are our 4 tools. So the first is our inspection. That's what we see. While we're talking to our patients and we're giving medications, we are assessing our patient. We're looking at things. We're looking at their skin. We're looking at their eyes. We're looking at the way they're walking. We're looking at their fingers. We're looking at everything. Palpation, that's when we're feeling. Percussion. So we're going to talk about percussion, but we do not expect you to percuss. We don't teach you to percuss. It's definitely an advanced skill if you were a nurse practitioner or a physician assistant. So we will talk about it, but we will not expect you to do it in the clinical setting. And then auscultation. So that's our listening. So inspection. So when we inspect, we are assessing size. So when we are looking at, if a patient has edema, we're looking at both of her legs together. We want to see if one side's bigger than the other. We want to look at the color. Is it red? Is it normal? Is it appropriate for ethnicity? What's going on? Is there any swelling? What shape is it? Does it have a huge knot in it? Does it have a hematoma in it? Is it shaped exactly how we would expect it to be and it's normal? What's their position? Are they sitting up nice and tall? Are they in a fetal position? Are they curled up? Are they guarding their abdomen? And then symmetry, making sure, so you always want to compare one side to the other side. So like, you know, if one patient has some cellulitis in their right lower extremity, you're going to compare it with her left lower extremity. If they have bilateral lower extremity, you want to look at both of them together to see if one side's bigger than the other. So then palpation, we use this when we're assessing temperature. So that's putting your hand on their head to feel their skin. When we're looking at their skin turgor. So if we're checking for if they're dehydrated and we pull on their hands. So a sign of, and we'll talk about this, but a patient that is dehydrated, if you can grab their hand like this and you pinch and you let go, if it stands up and it's tented, that is a sign that they are dehydrated. We call that tenting. You want to see if they've lost any elasticity of their skin. That happens in older adults. So is their skin very thin? Can you see their veins? Do they have skin tears? What's their texture like? Is it really, really dry? Is it really, really soft? Is it wet? Is their skin moist all the time? Do they have drainage? Vibration. So this is something that's very common in patients who have respiratory issues. And then shape, you're looking at shape and you're feeling for shape. So when you're feeling that abdomen, do you feel any abnormal masses or anything that shouldn't be there? And then percussion, that is assessing the location, the shape and the size and density of tissues. And when you palpate on your hand or when you percuss and you're tapping on your hand, you're listening for the sound that comes off over each organ or each area. And then auscultation, so that is assessing the 4 characteristics of sound, which are pitch, loudness, quality, and duration. So if you are doing an assessment and you're inspecting a patient, and you notice that they have a respiratory rate of 22, is that objective data or subjective data?
Objective.
Objective.
Very good. Dressing is clean, dry, and intact. Objective or subjective data?
Objective.
Objective.
Very good. Edema, swelling, and redness.
Objective.
Objective.
Very good. Nausea.
Subjective.
Subjective.
Good job. All right, so this is an important slide. So inspection. You want to inspect very, very carefully, very closely. You want to look, I call it the snapshot. You want to look first at the individual as a whole. So when you come in that room in the morning and you're doing bedside report and your patient's sitting in the bed, you're getting that snapshot inspection of your patient. So you're looking around the room. Are they hooked up to any fluids? Are they hooked up to any oxygen? What do they look like? Are they breathing comfortably? Are they using accessory muscles? Are their lips blue? Are they nice and pink and they're sitting up and they greet you with a smile? Are they hunched over in bed and they're guarding their abdomen? So this is going to give you that snapshot picture of the condition of your patient. So that's what I mean by first as an individual as a whole, and then we're going to look at each body system. So inspection is just concentrated watching. So this is where you're just looking at every single body part that they have and make sure that you're looking, you're just inspecting, you're looking. This begins when you first meet the person with that general survey. So when you're talking to them and you're assessing by communicating with them, you're assessing their neurological status, but you're also looking at their skin. You're looking at their mouth, you're looking at their eyes, you're looking at their pupils. You're doing a lot of things at once and you don't even realize it. Students get really overwhelmed because they think there's so many parts of the assessment, and really you're doing so many things at one time that you don't even realize it. As you proceed through the examination, start the assessment of each body system with inspection. Inspection always comes first. That's the first thing we do. Remember, we talked about 4 things. That inspection, palpation, percussion, auscultation. Inspection comes first. You always compare the right and the left sides of the body. We call that symmetry. Excuse me. Inspection requires good lighting. You need to be able to see what's going on. If you are a nighttime nurse and you're assessing your patient and it's 11 or 12 o'clock at night, they might not want you to turn the light on. So you just have to tell them, I'm sorry, Mrs. Jones, I know you're really tired. I just need to make sure that you're doing okay. I just need to take a quick listen and do a small assessment, and then I will turn your light back off for you. Make sure that you have adequate exposure. So if you need to look at an abdominal incision, make sure that you're pulling those covers back and you're pulling that gown off so you can really see what's in there. If they have wounds on their bottom and they're a very heavy patient or they're not able to turn, you're going to have to get your tech or another nurse to come in with you and help you turn that patient so that you can really look at that wound. And then the occasional use of instruments include an otoscope, which is what we use to look in the ears, an ophthalmoscope, which is what we use to look in the eyes. I use that in my practice as a nurse practitioner in my clinicals. I've never ever used it as a nurse. You may use it if you work in a primary care office, but you won't use it in a hospital. You want to make sure you have that pen light so you can check out your eyes and see other things. I've used pen lights for putting in Foleys too, because sometimes you just can't see all the little itty bitty parts that you have to find. A nasal or vaginal specula. So that is something that you would do. I've never used a nasal specula. I've assisted using a vaginal specula, like if you have a patient who's an OB/GYN patient and they have some kind of cancer and they come in and they do a speculum exam, you will assist them doing that. And whatever you need to help enlarge your view. So you do not want to rush through your assessment and your inspection. You want to take your time. You're going to compare the left side to the right side, and then you're going to assess and document whatever you find. So the size and the shape of the body parts and that comparison, that symmetry, okay? Which physical assessment technique is used to assess temperature, turgor, texture, moisture, vibrations, and shape?
Palpation. Inspection.
What do you got?
Palpation.
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 Yeah, palpation. Very good. So inspection was first. Palpation, what's next? Palpation, right? Inspection, then palpation. So palpation, you are going to apply your sense of touch to determine texture. So is their skin dry? Is it really, really hard? Is it edematous? Is it is it wet? Is their skin leaking? Or is it dry? Organ location and size. So after you do it enough times, you will be able to palpate around on the abdomen. You will be able to feel the pancreas at times, depending on the patient's size. You'll be able to find the liver. You'll be able to feel some of the bowels. It takes a while. Swelling, you're going to feel for swelling. So when we look at edema on patients, we are checking to see if it's pitting or non-pitting. So if it's pitting, when you push into their leg or their arm, wherever they have that swollen area, if it's pitting, when you push in and you pull your fingers back off, it's going to be indented. And we're going to talk about this further, but there's 4 different stages of pitting. So there's one where it just stays a little bit, and then 4 would be all the way to where it stays really long, and it takes like a couple minutes before it goes back to its original shape. So you're going to look at rigidity or spasticity. So looking at what kind of range of motion you're going to get from your patients, right? When you're assessing their strength and you're moving those muscles to see what they can do. If you have a patient who is not coherent and maybe they had a stroke, you're going to be checking to see for rigidity, because if we don't move them, they can get their fingers can get contracted. So we're going to check for that. Crepitation is when we're moving like knees and ankles through range of motion and you hear that crackling. That's crepitation. You're going to check for the presence of any lumps or masses, and then the presence of any tenderness or pain. So you're going to use your fingertips, grasp of the thumb and fingers, the back of your hand, and then the base of your finger. So those are the different types, the different parts of your body that you will use to palpate. The palpation technique should be slow and systematic, and it should be calm and gentle, especially with your patients who have cellulitis and edema, because they have so much pain. It hurts them to even walk. And if you just barely touch them sometimes, they will cry out in pain. So you just have to tell them what you're checking them for, telling the importance of it, and that they might be a little bit uncomfortable. Warm your hands by kneading them together or holding them under warm water. And then you want to use, the lightest amount of palpation that you need to determine the findings of your assessment, and then deeper if you would need to. And then you always want to palpate tender areas last. So you would use an example of like the dorsum, the back part of your hand is what you would use to measure temperature, right? I think we've all done that, especially we have kids. Your finger pads, we would use to assess firmness, contour, shape, and like tenderness of certain things. And then you also use these to locate your pulses. If you're checking lymph nodes on the side of the neck here, you would use those fingertip pads there, and then any other kind of small lumps that you're looking at. So percussion. So percussion is when you are tapping a portion of the body to elicit tenderness or sounds that are going to vary with density. So you tap the person's skin with short, sharp strokes to assess those underlying structures like the pancreas or the kidneys or the bowels. It is an advanced physical assessment skill that is usually performed, like I told you guys, by that advanced practitioner, that advanced professional, so the PA and the nurse practitioner. The sounds that you hear with that you would expect to hear would be tympany, resonance, hyperresonance, dullness, or flatness. And then we are looking for direct or indirect. So what do those sounds mean? So resonant is a medium pitched sound. And the only way you're ever going to be able to associate these sounds is if you do them. And it comes with a lot of practice. So unless you are an advanced practitioner, you're never going to do these sounds as a nurse. Resonant sounds, that medium pitch sounds, that's going to be with, if you were listening to like a normal lung tissue. That hyperresonant sound is going to be a normal sound that you hear in a child's lungs. If you hear it in adults, it's abnormal and it would be a sound associated with emphysema. I've never heard that sound myself yet. Tympany is a very high-pitched sound, so it's over air-filled areas, over the stomach or your intestines. And then when you're over that liver or the spleen or the pancreas, you're going to get that lower-pitched dull sound. And then flat is the lowest pitch of all of them, and that's over muscle or bone. They're more solid. So that is just a picture of somebody percussing. So auscultation, this is very, very important. This is listening to sounds that are produced by the body. So most body sounds are soft and must be channeled through a stethoscope. Stethoscope does not magnify the sound, but it blocks out extraneous sounds. Of all the equipment you will use, the stethoscope quickly becomes a personal instrument. Once you can recognize normal sounds, then you distinguish the abnormal sounds and those extra sounds. And that does take a while. So when you guys go to clinical, you're going to be identifying those normal sounds, and then you're going to start to hear eventually those abnormal sounds. I don't expect you to know what it is. I just expect you to go to your clinical instructor and say, hey, I heard something that doesn't sound normal. Can you help me? Can you come listen with me and tell me what you think this is? Because there's so many different sounds. There's no way you're going to know them all, and only through practice are you going to learn. You always want to make sure you listen in a quiet environment. So making sure your door is shut. I have no problem patients always, it seems like they always want to start talking as soon as you put the stethoscope up. And it's very hard for me to listen when they're talking. So I always tell them that I'm going to listen. And then if they start talking, I'll just be very kind and I'll just say, can you just give me 1 minute? I definitely want to talk to you, but I really want to listen to your lung sounds. I want to make sure that there's nothing going on. They don't have a problem with that. They want to make sure that you're listening. Let's see. So you're listening for, when you're using that stethoscope, you're listening for different characteristics. So some noises, some things you're going to hear are going to be high and low. Some patients' heartbeats are very, very prominent and very, very loud. Some of them you have to always go down to that and get that into that apical region to really get that maximum point of intensity. That's the only place you can hear it. Sometimes they will be very loud. Sometimes they'll be very soft. Sometimes you'll hear gurgling or swishing. So with your heart murmurs, you're going to hear that swishing sound. Your abdominal sounds, you're going to hear gurgling. Sometimes you'll hear short sounds, medium sounds, long sounds, especially with your bowel sounds. If they're hyperactive or hypoactive, they're very, very short and sporadic. If they're hyperactive, you're hearing a lot of them. They last for a long time. So conducting a physical assessment. The individual's perception of a positive physical and emotional well-being is what we call comfort. So you are going to start and you're going to ask your patient, are you having any pain today? Do you have any discomfort? Do you have to use the bathroom? Do you need help getting cleaned up? Or do you want to get cleaned up? And if so, do you need any help getting cleaned up? Do you need me to just set up things for you, or do you really need me to help you? What is your level of assistance? Asking them, are they comfortable? Did they get enough sleep or rest? Has it been quiet on the floor? Did they have any crazy neighbors next to them that were screaming all night long? So just making sure that your patient is comfortable. The presentation of a patient can tell you a lot about your patients. If your patients are shaking or diaphoretic, what do you think that would be a sign of? If you walked in and you saw your patient shaking and they were diaphoretic, they were sweating, what could that tell you about your patient?
Pain, fever.
Yes, could be pain, could be fever. So that would tell you, oh, this patient might have a fever. Let me go get the thermometer real quick and check their temperature. Let me really ask them about their pain. Let me see what's going on. So you're going to want to check their color. Their color is going to tell you a lot. So if they're appropriate for ethnicity, that means that if you're African American, based upon the color of your skin, that you look like you have a normal color. If you're Hispanic or if you are white, then based upon your ethnicity, you look normal. You don't have any pinkness, your lips aren't blue. So if they have any bluish area, usually around the lips is where you see it, or sometimes in the fingertips, we call that cyanosis. So this is, you can see cyanosis in the ears sometimes, the lips, around the mouth, that's the biggest place you're going to see it, the hands and the feet. So, and then those nail beds. So these can be, these conditions can be seen if the patient is just cold, but more so you're going to see it in cardiac and respiratory disease issues. It's usually a signal of decreased oxygenation. If you walk in the room and your patient has that bluish tint, you are going to want to check their oxygenation status because that's a good sign that they're not getting enough oxygen. So then pallor, that is the loss of color. So looking at those faces, the face and the lips, their conjunctiva inside their mouth, those mucous membranes, they get very, very pale and white when they don't have a lot of good blood flow. You'll see that in patients that have anemia, some patients that have sickle cell, I noticed that. Anemia is caused by decreased hemoglobin levels, so they're not getting enough of that oxygen-rich blood. So then those areas get very pale because they don't have a lot of blood flow to them. And then you would see this in patients that have shock, if they're going into shock, because they have that decreased blood volume. Then we have jaundice. So jaundice is where they would have a yellowish tint to them, and it's going to be all over their area. All over their body. So it's going to be their mucous membranes. It's going to be in their skin, in their sclera. And this is caused by patients that have liver disease. It comes from an increase in their bilirubin levels. So a lot of patients who are alcoholics, who have cirrhosis of the liver, any kind of liver disease at all, it's very common for them to be jaundiced. It's very, very, very easy to see in a white person because they turn yellow. If you have an African American or a Hispanic person where their skin is already a tannish color, it's going to be very hard for you to tell. So where do you think the best place is that you could assess for jaundice in, say, an African American? Where do you guys know? Yes.
Their eyes.
Very good. In their eyes. Very good. That is important information. You might hear that again. So then we're looking at redness. So erythema, flushing. If they have a fever, you might see flushing. They're nauseated, they were vomiting, you may see flushing. They're having an anxiety attack, you may see flushing. Erythema, so that's going to be redness or swelling from cellulitis somewhere. The area of the skin is going to be red. It can be anywhere. It can be a very localized area on the body or the skin. It can be the facial area. It can come from infection. It can come from injury and trauma. Alcohol intake can cause that sometimes. You also want to inspect the skin. You're making sure that if you notice any lumps or bumps, you ask the patient if they were aware they had them. And then you want to make sure, like sometimes not every patient can see the back of their back, right? We don't always look at ourselves in the mirror. We don't always do good skin inspections on ourselves. So if you ever notice something on your patient's back, you can just say, Mr. Jones, did you know that you had a small red lump on your back? Oh yeah, it's been there for years. Okay, that's fine. Or they'll say, yeah, I just noticed that last month, but it wasn't pink. It was barely noticeable. Well, now it's changed size and color, grown in size. Those are things that are going to make you think, hey, this is probably not something normal. So
Ms. Davis, one question before we move on.
Yeah.
So the sickle cell patients, their eyes are yellow too. That's not with jaundice though, right? It's not the same. Is it?
They don't usually have sclera. I've never seen them have that with sickle cell.
Okay.
That's just with,
You saying their eyes don't be yellow? It's not
no.
usually.
I've seen somebody with sickle cell too with yellow.
Oh, you did?
sclera,
Yeah,
so-
yeah, because I have family members that have
Oh, okay.
sickle cell
All
and their
right.
eyes yellow, so I didn't know if they was connected or not.
Oh, okay. I've actually never seen that. So that's good to know. Thank you for sharing that. I didn't know that. Okay, so inspecting the skin. So here is what cyanosis looks like. You can see these hands right here. See the bluish color right there, especially on those fingertips. That's a bad sign. I want you guys, if you ever see that around their hands or their mouth, I want you to automatically think something's going on with their oxygenation. Right down here, we have, it's kind of hard to tell, but this is jaundice. So this side is normal skin color and over here is jaundice. Here is just some of that bruising, erythema, redness. This is the typical arm of an older person. Their skin gets very, very thin. And if you just touch them, they bruise very, very easy. And then over here, so these are our ABCDs. So this is actually melanoma, which is just like the slide says, 100% curable if it is caught early. So when you see any of these little things on your patient, you always want to look at them. So you're going to check for asymmetry. And that is if you pretend like you draw a line through whatever mole or area you're looking at, if the two halves will not match, they're asymmetric, right? Because if they're symmetric, both sides are going to be the same. The borders of early melanoma tend to be uneven and the edges can be scalloped or notched. So you can see that border right there. That's a good example. And then the color. So when you have moles or areas that have a variety of different colors, that is also a warning sign. It can be a number of different shades of brown, tan, there can be black sometimes. Some melanomas can be red, have specks of white in them, or they can even be blue. And then you want to look at that diameter. So melanomas are usually long in diameter. They're usually longer than the size of an eraser on your pencil, which is 1/4 of an inch or 6 millimeters. But sometimes when they first start out, they're smaller, obviously. And then you want to check and see, it's not listed on here, but you can also add E. So you want to see, is it evolving? So is there any change from the last time you saw it? Is it changing in size? Is it bigger? Is it changing in shape? Is it more elevated than it was before? Has the color changed? Do you have any new symptoms? Have you scratched it? Is it bleeding? Does it itch? Do you have any crusting over top of it? Those are all bad signals. So if you have, let's see, you just want to make sure that if that patient tells you that they have had a mole or that anything's changed, if it's gotten larger or it's changed colors, you would want to contact the doctor and let them know, or you want to encourage the patient to follow up on that, okay? Important stuff there. Pressure ulcers. As a nurse, you want to prevent these. These can happen within 12 hours of a shift, within 6 hours of a shift. So over here shows you our subcutaneous tissue, our skin. So this is a stage 1 right here. So her skin, his or her skin right now is not open. You can see that little area right there on the left side of her bottom. If it's blanchable, and by blanchable, I mean you push on it with your finger and then you let it go. If it turns white for a second, and then when you let it go, it goes red again, that means that it's getting good blood flow to the area. If it's non-blanchable, that's a problem. So if you push down and you let go and it stays white, there's no blood flow getting to that area. That's a problem. They're going to continue to have more skin breakdown. This is why we are turning our patients I swear to God, this is like, I feel like this is all I do as a nurse, is prevent wounds and turn my patients. And I'm always like looking at them to see, are they capable of turning themselves? It's such a huge thing that we do as nurses, because these wounds can go, I mean, I've seen patients die from from wounds because the infection gets so bad and then it goes to their bone and they get osteomyelitis and then they can't fight off the infection. And then it costs so much. So if your patient comes in and they don't have any wounds and then they get a wound, the hospital pays for that. And they can cost upwards of $60,000 to $70,000 for just a small stage 2. It's very expensive. So stage 1, the skin's not open. Stage 2, now look, it looks like a skin tear. That first layer of skin has come off, but we can't see anything else, right? Just that first layer of skin has come off. Now we have a stage 3. So now we're starting to see a little bit more, some of that subcutaneous fat maybe. And then a stage 4, well, you could see muscle, you can see bone. I've had patients, just the other day, I had a guy who was a quadriplegic and he had a wound in his back that he's had for like 2 years now. It was this big and I could just see his spinal canal as soon as I looked through. You can see bone, you can see fat, you can see tendon, you can see muscle. And then this little area right here, that part is actually has slough on it and that's unstageable. We don't know what's under there, so we can't give it a stage. So that would actually have to go in surgically to be debrided, to pull that back to see what's under there, or you would have to use some kind of pharmacological agent to put on there that would actually debride that. So anytime you have that slough, you're not going to be able to determine what's under there. It's going to be considered unstageable.
Mrs. Davis?
Yes.
I know we're supposed to wait, but I just had a question that I just can't, I have to have the answer for. Are those ulcers, they're unavoidable, correct?
They are avoidable. Absolutely.
Right, I'm saying they are like, they are avoidable. Like they
absolutely
have to happen.
Absolutely. They do not have to happen. It is completely preventable by us as nurses.
That's what I was trying to figure out.
Yep.
Where they come from. Like that was
yes.
it.
Yes, they come from patients sitting in the same position in those bony prominences and not turning them.
Okay.
Yep.
A quick question, Ms. Davis, sorry.
So look, I'm going to answer one more question, but I'm not going to answer any more questions. We have to wait to the end. Okay.
Okay, just about the stage 4 ulcers.
Okay.
Said that when you can't, like when you've got the, when it's so deep you can't even stage it, or is that always like only in stage 4 at that point?
No, so that is anytime that you see that yellow mucky stuff on there, that slough, that could be just maybe that's only a stage 3, but we don't know or maybe it's just a stage 2, but we don't know because we can't see what's under that area.
Okay, thank you.
You're welcome. And I'm not trying to be mean. It's not that I don't want to answer your questions, but there are other students who can't always stay on. They have other commitments with their family and stuff like that. So I just want to be mindful of them and I don't want to keep them after. So I just want to hold all questions to the end. I just think that's fair. So our nails. So we want to look at their nails. You want to look at their length, especially in the older people. You want to check to see if there's poop under them. That happens all the time, all the time. Sometimes they're just confused and they dig in their bed and they get poop on them. Sometimes they come from the long-term care facility with poop under their nails. They get confused. They don't know what's going on. So if you see that, please clean their nails, soak them in a little bucket of water. You want to look for the angle between that nail and the nail bed. You want to check for clubbing. So clubbing is, it's when the angle of the nail is greater than 160 degrees. So you're going to see this in your patients that have emphysema, your patients that have COPD. So any of those chronic low oxygen saturation issues that are related to lung disease, chronic bronchitis, you're going to see that in their fingernails. And when you see it, you will know it. It's very, very prominent. So, and we're also going to check when we're looking at their nails, that's one of the places we're going to do capillary refill. So we're going to push on that nail and then it's going to turn white. And then when we let it go, that blood flow is going to come back. We're going to talk a little bit more about that, but our fingernails is one of the places we're going to do that. If you can't do it on their fingernail, you can, because some people have fingernail polish on, the same thing with the toes. That's the other area you're going to check cap refill. You can do it on the back of the finger. You just push on the back of your finger and then let it go. You can see that blood flow come back. So it doesn't always have to be the nail. So we are going to look at their scalp. So we're going to look at their hair. We're going to see, do they have any missing patches of hair? Are they a chemo patient? Are they losing their hair? Do they just have patches here, patches there? Are they thinning? You're going to want to look at the color of their hair. Do they have gray hair? Is it straight, curly, or kinky? I've never documented that for a patient. They've never asked. I've never seen that at any of my documentation, but you want to look for uneven distributions of hair patterns and hair loss, and then any kind of lesions. So do they have any lesions in their head? If they had a fall, did they bust their head? What's going on? Do they have a scab there? Does it need to be treated? Check behind their ears to see if sometimes they get very dry patches, especially those older adults right behind the ears. And then check for head lice. I've never had a patient, well, I'm not even going to say it because it'll happen, but check for head lice. So our sensory perception. So when we're looking, so sensory perception is the process of recognition and interpretation of our environmental stimuli. So we're going to look at their eyes. So we want to look at their eyelids. So are their eyelids open? Are they symmetric? Is one lid puffy and then the other one's fine? Is one of them, like if you've had a patient that has a stroke, you might have one eye that's completely open and looks completely normal, and the other one may be very droopy because they don't have good muscles on that side of the face from the stroke. You want to look in the corners of their eyes, and do they have any pus or any kind of drainage, or their eyes tearing up? Any swollen areas on the eyes. This is where we're going to check for PERLA. So PERLA, P-E-R-R-L-A. When you talk about it and you document it, that's exactly how you write it out. You would write PERLA. PERLA stands for pupils equal, round, reactive to light, and accommodation. If you assess your patient and you do PERLA and everything is normal, that's exactly how you would document it in your progress note. You would just say PERLA and then put a period. And then that's how everyone would know exactly what you're talking about. So you're looking at those pupils and you're going to compare one pupil to the next pupil. So you're going to want to see what size they are. Usually your pen light has little circles on the side. And it shows you 2 millimeters, 3 millimeters, 1 millimeter. You want to try and compare it. You want to make sure that they're both the same size. You want to make sure that they are the same size for the situation that you're in. So if they're dilated or they're pinpoint, if they're really, really huge, that could be a sign that they don't have any brain activity. We would say that their pupils are blown when they get really big and they take up that whole area of the eye. If they're constricted, it could be that they're on some type of drugs if they're pinpoint. So you're going to look at those pupils. Then you are going to make sure that both of them are equal. Make sure both of them are round, that they're not a different abnormal shape. And then you want to know if they're reactive to light and accommodation. So you're going to take that pen light, you're going to let them know exactly what you're going to do. You're going to start out on, doesn't matter what side of the eye, you start out on the outside of the eye, you turn your pen light on, you come in, and then you go back out. And when that light goes across that eye, it should constrict. That's what you want it to do. Then you move over to the other side, you bring your pen light in, make sure that that eye, that pupil is constricting. In older adults, it's very common for you not to see it constrict. We call that sluggish. That happens when they get older. You might not even see it, or you might just see it constrict just a tiny bit. And we call that sluggish. All right. So, oh, you don't have this one chart. I wanted to show you. Let me see if I can add it here. Okay, so this is the pupils. So the top is pupils are equal and react normally. They're both the same size. They react appropriately when you use your pen light. Pupils react light, so slowly or briskly. Are they sluggish or slow, or does it happen quickly? a dilated pupil, that can be a sign of a compressed cranial nerve or some kind of irreversible brain damage. You can see how this pupil here is a lot smaller than this one. And then this one here is a lot bigger than this one. So are they dilated and fixed? This is, like I told you, a very ominous sign if your patient's pupils look like this. And then pinpoint. So this could be drugs or damage to the pons area of the brain. So again, we are going to inspect those external structures, the eye color, the alignment, their eyelids, their lashes, their sclera, their lens and their pupils, looking for anything abnormal. You're going to note any discharge coming from those lacrimal ducts. Note any masses or lesions or tenderness. Assess the patient's ability to see or their need for glasses or contacts. And then that's more so in the primary care setting. And then assess those extraocular movements. So you can do that with your finger or your pen light. Most people, I always do it with my pen light because I have it in my hand if I'm checking their eyes. So that's where you hold it in front of them and you move the pen up, and then you go to all those, see those different directions. You go and you make sure that their eyes follow with them. Oops. So, your slides are completely different than mine. I don't know why. All right, so pupillary accommodation. So you're going to ask the patient to focus on that object as it's brought closer to the nose. The pupils normally constrict when they're looking at an object that's near to them, and they dilate when they're looking at a distant object. So again, that's pupils, that perla. And then the pupillary reaction is when you're bringing that pen light from the side of the face and briefly shine the light on the pupil. And that convergence is when you hold the finger or the pen light 6 to 8 inches from the bridge of the nose and move the finger towards the client's nose. And the eyes will converge to a cross-eyed appearance. And this is an important slide. You guys need to know that. So, eyes. So assessing visual acuity. If you are assessing someone's visual acuity, you're going to use the Snellen eye chart. You would have the patient stand 20 feet from the chart. Ask that patient to read the smallest line of the letters possible. First with both of their eyes, and then you have them cover up one eye and do it one eye at a time. And then you note whether the patient's vision is being tested with or without corrective lenses. So do they have their eyeglasses on? So visual acuity is measured by using standardized numbers that are listed on the side of the chart. The numerator is 20. That represents the distance in feet that the patient was from the test. The denominator represents the smallest line read accurately by the patient. So our visual acuity is always recorded as a fraction, and it's written over 20 over the smallest line read by the patient. And they don't want any more than 2 inaccurate readings. So you would say my patient has 20/30 vision with glasses, or my patient has 20/20 vision, which is the best vision you can have with no assistive devices. So the larger the denominator, the poorer the patient's vision. So what type of visual acuity issues can we see in our patients? So if your patient has myopia, that is nearsighted. So there's a decreased visual activity at a distance. So you cannot see at a distance. So you would assess that via the Snellen chart. You have farsighted, or we call that presbyopia. That's decreased visual acuity in a close range. To assess that, you could use something called the Jaeger card. I've never seen one or used one. And then we have your peripheral vision test, which is assessed using the confrontation test. But you guys are probably not going to be doing these unless you work in a primary care office. So this is an ophthalmoscope, which is what you use to do an examination. we don't do this as nurses. I've never done this. I've never seen a nurse do this. Maybe if you work for an ophthalmologist, that could be your scope of practice. It's definitely not mine in the hospital. You would make sure that the room is dark. You want to turn it on, and then you want to use the lens selector disc to find the large white disc in the eye. You're looking for optic disease. You want to look at their retinal vessels to see if there's any kind of damage. You're just assessing the overall background of the eye, and you are looking at the macula. This is a very advanced skill, and I will not expect you to know it, and I will not test you on it. It's just information.
Miss Davis,
Yes.
I think Kelsey got knocked off.
Thank you. All right, so the ears. So we are going to inspect the external part of the ear. So we want to look at the size and shape of the auricle. We want to look at the position and the alignment on the head. We want to note any type of skin conditions. So what color are their ears? Do they have any lumps? Do they have any lesions? Does their ear color match their face color? Do they have any foreign bodies, any kind of discharge inside or outside of the ear? You want to check the movement. So sometimes patients might not say they have any pain in their ear, and then when you pull down or you touch the inner part of the ear, that auricle or that tragus, it can be very tender. That could be a sign of like an ear infection. And then you want to evaluate the external auditory meatus. You want to look at all those areas. You can look in here to see if they have, sometimes if your patients say they can't hear, they might have earwax buildup. You could send them over to the ENT clinic. Because sometimes those older patients, they can't hear, and maybe they don't need hearing aids. Maybe they just have to have their ears cleaned out. So this is an example of swimmer's ear. So this is a normal ear here, just maybe a little bit of dryness right there, but you can see this whole area here. We would call this edematous. You can see that the skin's wrinkled. It's filled with fluid. It's really, really puffy. There's erythema there. It's very, very red. So using those nurses' words, so if you wanted to describe that to the doctor, you would say that it is edematous and there's erythema. So you're telling him that it is filled with liquid and it is red. So you want to ask your patients, are they hard of hearing? If so, which ear? Do they have issues with both ears? What is their good ear? Do they wear hearing aids? If they do and they don't have them, can you contact a family member and have them bringing them? Because you want to make sure that the patient is able to hear everything, so that way they can really participate in their care and that they can understand what you're telling them. So when you're educating them, they know what to expect when they go home and really understand things. So if you're using that otoscope to look into the ear, you would go 1/2 inch into the ear. You might see cerumen, which is just earwax. You would assess for a reddened canal or any kind of discharge, which could indicate an ear infection. And then you would want to look at that tympanic membrane to make sure it's intact, make sure that it's not red or inflamed in any way, which could also indicate a ear infection. So an otoscope size depends on the diameter of the auditory meatus. So obviously, if you had a really small one, you wouldn't want to choose a big one. And I think we've all been to the doctor's office enough, and we've probably seen the different sizes that they have. You want it to fit comfortably in the ear without causing any damage. When you're looking in their ear, you want to tell a patient to tilt their head away from you and towards the opposite shoulder. So when, this is important, you will see this information on your board exams. With the adult patient, you're going to pull that pinna up. So this is the top part of the ear, the pinna. You're going to pull it up and back, and that's really going to help you look inside that ear. Now, if you're doing it for an infant or a child under 3 years old, you're going to pull it down and back. Okay, so with the adult, you're going to pull the pinna up and back, and with the child, it's going to be down and back. And you're going to hold the otoscope in a position that seems upside down to help you balance the otoscope during the exam. And this decreases the risk of damaging that tympanic membrane inside the ear. So if you looked inside and you visualized the tympanic membrane, this is what you would see. You would see this you want to see this little shiny area right here. You want to see that shiny area in your tympanic membrane. That represents a normal tympanic membrane. This one over here, very, very abnormal. A lot of redness. You have some swelling. Looks like this little pus-filled cavity right here. It's very common for patients, especially children, that go undiagnosed with ear infections. This tympanic membrane can rupture. Very, very painful until it ruptures. Once it ruptures, they don't have a lot of pain because the pressure is relieved. It can heal, harder in adults to heal, easier in children. But you always run the risk of having some type of hearing loss, permanent hearing loss from that. So you want to see that translucent, shiny, pearly gray. That's what you want to see. You want to note if it's flat or if it's bulging or retracted, and then the integrity of that membrane. So is it open? Is there a hole in it? Is there anything draining from it? And then testing the hearing acuity. So you would do this because you would want to note behavioral responses to your conversational speech. You can do a voice test, which they do in ENT's offices, or you could use these tuning forks, which were created by Weber and Rhine. I have never, ever seen a tuning fork, and I have never, ever used one. It is not an accurate measurement tool that we use today. Is what the book tells us. I've never seen it. I don't work for an ENT. We use the whisper test somehow. We'll talk a little bit about that. So the whisper test is when you test one ear at a time by muffling the sound in one ear by placing your finger over the tragus and rapidly pushing it in and out of that auditory meatus, which is that little hole. You stand behind the patient so they can't read your lips. And then in the other ear, when you're about 2 to 3 inches from the patient's ear, you slowly whisper 2-syllable words. And then you have the patient repeat those words back to you. And then you do that same thing on the opposite ear. So you could say things like ice cream, armchair, baseball, 14. I've never, ever done this either. These are like specialty things. So we will talk about that tuning fork test that was created by Weber and Rhine. So it is basically a test that looks at bone conduction with the bones in the ear. So you would place this, that tuning fork that I showed you, or that they're showing you in the picture, on the vertex or the midline of the forehead. Then the vibrations would be conducted through the skull and it would reach the cochlear area of both ears. You would ask the patient which side of the ear they heard the loudest, if it was the left or the right or midline, which would mean that it would be the same in both ears if they heard it midline. In conclusion, the ear which heard the lower sound is going to be the one that's going to be examined or tested further. That's considered the Rhine test. Before you perform the test, you're going to make the patient cover the opposite ear with their hand. Then you perform the vibration of the tuning fork and place the vibrating fork onto the patient's mastoid bone to initiate that process of testing the ear. You ask the patient to report when the sound can no longer be heard from the ear you're testing. And after the patient can no longer hear the tuning fork, you move the vibrating tuning fork to the adjacent ear canal and make sure that it's oriented in a position that is perpendicular to the ear. So you can see in that last picture. And then the patient should indicate when they can no longer hear the sound, which is conducted via the air. It's very complicated. I've never done it. You're never going to do it, but we just have to talk about it. So communication. You can assess someone's skin and assess their communication at the same time because you're inspecting with your eyes, you're listening with your ears, and you're communicating with your mouth. So while you're looking at that skin and you're looking at that snapshot of your patient, you are assessing through communication their mental status. how well they can communicate. So what is their speech like? Is it clear and can they articulate well? Is it a decent pace in conversation? Is any of their speech delayed? Does it take them a couple seconds to respond to you? Do they really have to think about what they're trying to say? Are they using appropriate word choices? So if you say, do you have any pain? And your patient says, the car is hot, then that's going to be a sign that your patient probably has some type of expressive aphasia. They are not using the right word choice. Do they have any communication barriers? So are they blind? Are they deaf? Do they need any assistance? Do they have an understanding of the events, what's going on in their surroundings? So do they know who they are? Do they know where they are? Do they know why they came to the hospital, what the date is, what the year is? Are they able to communicate effectively? Can they communicate in an age-appropriate manner? So your patients who are developmentally delayed might not have a huge language library to choose from, so they might not use the words that you and I would use. Maybe their cognitive ability is only that of a 3-year-old or a 4-year-old. You want to assess the patient's ability to read or write. If they have aphasia, you want to be able to document what type. So that expressive aphasia is that partial loss of ability to produce language or the right words. Receptive aphasia is when they have difficulty understanding written and spoken words. And then global aphasia is when clients who can produce very few recognizable words and understand little or no spoken language at all. And these are really seen with our patients who've had strokes. This is where you see a lot of those issues. So the oral cavity, you want to check their mouth. Again, you're up there with your pen light, just go, as soon as you look at their eyes, go ask them to open their mouth. You want to look for any areas. Do they have teeth? Are they missing any? Are they missing any teeth? Do they have dentures? Do they have fixed dentures? Maybe dentures that don't come out. You can even ask them because sometimes you can't tell if they're dentures. Do they brush their teeth? What do their gums look like? Are they a nice coral pink and very close to their teeth with no bleeding? That is good gum tissue. Are they really, really red and swollen? Do you have any bleeding? Look at their lips. Are they blue? Do you have any cyanosis going on? Are they nice and moist and symmetric? Is there any swelling? Are they really, really dry and cracked? Like you think they're dehydrated? Do they have any lesions? Looking in the pharynx, you can look in the back. So you see this picture here, this is tonsillitis. So you can see these tonsils back here, the top picture, they're very, very small. You can see here that they're very, very swollen, and sometimes they develop into what we call kissing tonsils, and these will actually start to touch. So you could expect that there's going to be a huge problem with this patient's breathing here because they're not going to get adequate air in because of the swelling in the throat. You want to look at their tongue, make sure that it's not swollen, that there's no open areas, they don't have any lesions inside their mouth, look on the roof of their mouth, make sure they don't have any ulcers. This is particularly important for your cancer patients. Because remember we said that they get chemotherapy and they can get a lot of those ulcers and sores inside their mouth. And really doing this good examination of their oral cavity is important to identify areas that could be causing any nutritional issues. We'll talk about that when we talk about nutrition, but the composure of someone's mouth, if they have sores or open areas or problems, that's gonna make it, one, it's gonna interfere with the way they taste food, and it's gonna make them not have an appetite, which will, if they don't have good nutrition, then they're not gonna be able to heal properly. Make sure you're wearing gloves when you assess their mouth because you have some bodily fluid there. You can use a 4x4 if you want to hold down the tongue to look. You can use that long wooden stick to push their tongue down if you need to be. You can ask the patient to reposition their head various ways so that you can really get in there and take a good look at what's going on. So when we're inspecting that face, we're going to look at the nose. We're going to look at the outside of the nose. Make sure, if you look at this picture up here, this guy has a deviated septum. You can notice that there's obviously something wrong with his nose. So if you were going to place an NG tube in a patient like this, which is a tube that goes through the nose and into the belly, you would not want to choose his left side of his nose because it's not a clear way for you to go. You know, there's going to be some kind of obstruction there. So you want to palpate their sinuses. So your frontal sinuses are here, palpate the eyelids, palpate these maxillary sinuses here, see if there's any pain. You want to look for drainage, redness in the eyes, in the nose, in the mouth. Again, looking at that skin color, palpating those sinuses. We want to look at the neck. So when we're visualizing that patient and we're looking at them, remember you were going to use your fingers and you were going to feel in this area to see if you see any swollen lymph nodes. It's very common for patients that have the flu or any kind of pneumonia or bronchitis, any kind of inflammatory response in the body if they're sick, that those lymph nodes swell up. That's a normal part of our compensatory mechanisms in our body. So it's very common that you might feel swollen lymph nodes there. But you would want to take note and document how they are so that you can use them as a baseline to determine if they're getting better, if they're decreasing in size, or if they're getting bigger. You want to make sure both sides of the neck are symmetrical. Those lymph nodes, you want to look at the trachea. You want to make sure that it's midline. If it's shifted, that's a huge problem. Patient's not going to be able to get good air in. You want to look to see if there's something called jugular vein distension. We call that JVD. Actually, I'm going to wait to talk about that because that's the next slide. You want to make sure you want to check their range of motion. Can they move their neck back and forth to the side? Can they point it forward? Can they point it back? So then that JVD. So you will see JVD in patients who have what we call left-sided heart failure. If you have your patient laying in bed, you can have the bed at like 30 to 45 degrees. You have them turn their head slightly and you look at the side of their neck. You are assessing for, see that big vein right there? You are assessing for visual pulsations. You will physically be able to see that pulse inside that vein. You'll know it when you see it. You're going to look in that area. That is going to be a sign that your patient has fluid overload or they have some kind of left-sided heart failure. You can assess for a bruit, which is caused by narrowing in that vessel. You want to do this if you're going to rule out for a stroke or a TIA, which is just a small attack. It's kind of like, it's a preempt to a stroke, but it's not where it's very quick and very short-lived, and they usually don't have any side effects, but it is a sign if your patient has them that they are probably going to have a stroke in the future. And those strokes and those TIAs are caused by plaque buildup in those vessels. So you would want, if you want to do the bruit, you would palpate that artery, okay, with your finger, put your finger pads, put right over top of it. You want to determine whether there's a thrill or a slight vibration is present. That's what we call it, a thrill. You can feel it. A bruit is when you would be able to hear it with your stethoscope. So a thrill you can feel. We also do this. We don't do it with this. We also do it with patients that are on dialysis and they have fistulas in their arm. That's part of your inspection. You are going to check their fistula to make sure that it has good blood flow, and you check for bruits and thrills. So thrills you feel, it's a slight vibration. And then you would take your stethoscope, put it over that carotid artery, start at the jawline, ask the resident to hold. Just have them take a deep breath in and then lightly press that diaphragm while moving down that length of that artery all the way to the clavicle. And then you do it on the other side. And if you hear a swishing sound, that means that the vessel is narrowing, or if you feel that vibration. So in JVD, you don't want to feel it. You don't want to feel it and you don't want to hear it. In your diabetic patients that have those fistulas, you want to feel it and you want to hear it because that means that their access for getting their dialysis is working appropriately. All right, oxygenation. It's the process that maintains oxygen levels necessary for the survival of the living cells and humans. So subject,
I'm sorry, Ms. Davis, did you skip over the fingers? Did we do the fingers?
we did the fingers.
I must have missed that one.
Yes, I'm recording it, so you're going to be able to watch it. So oxygenation questions. So some subjective data. Do they report any difficulty breathing or having shortness of breath? When we talk about difficulty breathing and shortness of breath, we have what we call dyspnea on exertion. So DOE is how we put that, dyspnea on exertion. So this means that when the patient is exerting themselves, they get dyspnea, which is shortness of breath. We also have dyspnea at rest. That means that they're not doing anything. They're sitting in their bed and they get short of breath. If they're reporting a cough, you're going to want to ask more information. You have a cough, is it productive or non-productive? If they tell you it's productive, you're going to want to say, is it thick or thin? And you're going to want to know what color it is, and you're going to want to know how much they are bringing up. If you document in your assessment that a patient has a productive cough, you need to document all those other things behind it, because that creates a trail for other people to go back in and say, well, 3 days ago, Mrs. Jones had a productive cough and it was green. Today, it's a productive cough and it's just very little and it's white. So that shows that the patient's antibiotics are working and that their cough is improving. If they report hemoptysis, so that is coughing up blood. If they report a history of smoking, you want to ask further. You want to know how many packs a day they did smoke or how many packs a day they do smoke. If they quit, you want to know how long they smoked for and when they quit. We just talked about this, the shortness of breath with certain activities. Orthopnea, so do they have difficulty breathing in any other position except erect or in a standing position? So orthopnea is something very, very common that you see in patients that have COPD and emphysema. These patients usually sleep in their recliners. It's the only way they can sleep is if they're straight up. It's the only way they can get that good oxygen into their lungs. Even when they come in the hospital, I've had patients that won't even get the bed. They just stay in the chair the whole time because that's where they're comfortable. So that's orthopnea. You want to ask, has anyone in your family have lung cancer or any tuberculosis? So any of those lung-related issues. Ask them, did they receive a flu vaccine each year? And have they gotten a pneumonia vaccine, especially for those high-risk patients? So your immunocompromised patients, your patients that have emphysema, COPD, your older adults, they're all at risk. So you want them to have those vaccines. So when we talk about coughs, do they have a dry cough, which could be caused by anything? They could just have an allergy to something. They could have, seasonal allergies, morning allergies. They could have cardiac problems. Sometimes we see this in HIV patients. Do they have a moist cough, which is caused by an infection and can be accompanied with sputum production? Not all the time. Sometimes they can't get their sputum up. If a patient tells you, I do have a cough, but it's non-productive and it's driving me crazy, advocate for your patient, call the doctor and say, can we get the patient some guaifenesin or, oh my God, I just completely lost the word. It's guaifenesin or, I can't think of the brand name right now. I say it all the time. It was just on the tip of my tongue. This medicine, when they take it, it helps thin their secretions. So it brings more fluid into the lungs, not so much that it would cause more respiratory issues, but just enough that it thins out the secretions. And then when they cough, they can get it up. Let's see, if you're preparing, let's see. So if you're coming in to do an examination on your patient, okay, your patient came in because they had a knee replacement. And then when you're talking to your patient all of a sudden says, I'm really short of breath. Where would you start your assessment at? Would you go ahead and go to that knee and look at that infection issue because they just had surgery, where would you start your assessment? What would you guys do first?
Check their lung.
Say that again.
Listen to the lungs.
Listen to their lungs. Very good. So that's making that priority assessment. So we talked about, you're gonna, when you're doing that ADPI, you're doing that nursing process, you're doing that assessment data, you're gathering all that information so that you can, excuse me, form a list of problems for your patient. Then out of all of those problems, you're gonna pick the priority diagnosis. So in this case, it would be the shortness of breath, ABCs, right? Airway, breathing, circulation. You need to be able to pick out that priority assessment. Let's see. So inspection. So when we're looking at the chest, we are assessing their thorax area, looking for symmetry. So this is a normal adult chest right here. This is a barrel chest. This barrel chest you see with patients that have emphysema and COPD because their lungs are overinflated because of that drive for the oxygen and how they're always struggling to breathe. The color should be consistent with their face. The shape and the contour should have kind of like a downward equal slope at the rib cage. Both sides of their chest should be symmetric. In women that have breasts, it's very common that one is bigger than the other. That's not an abnormal thing. That's very normal for a lot of people. You're going to assess their respiratory rate. So you will learn eventually when you come into a room and you're doing that snapshot, you're gonna automatically know that their respiratory rate is not normal if it's in the 20s or the 30s. You're gonna be able to see it. They're gonna be breathing very quickly. The depth of their respirations are gonna be deep or shallow. They won't be normal. You're going to be able to tell if somebody is breathing normally and they're comfortable, or if they're breathing and they're using those accessory muscles. So when you breathe in and their shoulders go up, or you can see like the bones in their neck sometimes because they're breathing so deeply. You're going to look at the rhythm of their breathing. So is their rhythm regular or is it irregular? And then their work of breathing using those intercostal muscles. All part of that inspection. So when we palpate the chest, you can assess the thorax by using the thumbs. Placed on the patient's back. So as the patient inhales, the examiner's hand should move apart, right? So that's showing you that you're getting that good airflow in there and the lungs are expanding. And you can see as he takes the deep breath that the hands come apart right there. You can do something called tactile fremitus, which is where you palpate the chest wall using the palms of your hands. And you're comparing side to side, so from top to bottom, and then you ask the client to say 99 each time you're doing that. And they're just gonna keep saying it, 99, 99, 99. And as you're moving your hands, if you feel any vibrations, that would be tactile fremitus. I've only done that one time in my entire nursing career. I've only been a nurse for 7 years, but I've only ever done that once. So it's not something that we do all the time. All right, on to the good stuff. Auscultation. So we use this to detect airflow in the respiratory tract. We are listening for abnormal sounds. When you're doing this, so all these little numbered areas, these are all the areas where you're going to assess the patient on the front of the chest and the back of the chest. These are very detailed assessments. In the hospital setting, we do not do lung sounds this extensive unless it's warranted. Unless you hear a sound somewhere, you're gonna explore deeper and then really do a good lung assessment. Or if something changes. I'll show you which ones on Saturday that we always do. You just have to understand part of this whole head to toe physical assessment is going to seem like it's a lot for you, but what I want you to understand is that you are not always going to do that 45-minute head to toe physical assessment on every patient, but you need to know every component of it in case you ever have to use it, and you have to know when to implement it. So in the hospital, you do a very focused assessment. You're doing, you're checking their heart sounds and lung sounds and abdominal sounds every single day. If they came in because they have swelling, then you're checking pulses. If they're older and they're not able to turn in bed, then obviously it's a more detailed assessment based upon why your patient is admitted into the hospital. So these are the locations of the areas where you're going to listen. You'll always ask the patient to breathe slowly and deeply through their mouth. Make sure that the diaphragm is warm if you can. You're going to put them over top these landmarks, and you're going to listen in a very sequential pattern. You're going to hear, sometimes you're going to hear great airflow. It's going to be very easy for you to hear. Sometimes it's going to be very diminished. Patients that are older, it's very, very common for them to have diminished lung sounds, so it's going to be very hard for you to hear them. You're going to be listening for abnormal things like crackling and wheezing, things like that. What I tell my patients is I tell them that I'm going to listen to them so they know exactly what I'm going to do. And then I ask them, when you feel my stethoscope, please just take a deep breath. I feel like it's always easier to hear in the front anteriorly than it is in the back. So you have to have them be a little bit more quieter. And then I tell them, every time you feel my stethoscope, just take a deep breath. And then they know when to take a deep breath, because then you're also listening to them, to their heart sounds too. And you don't want them constantly taking deep breaths when you're listening to the heart sounds. You always just want to tell them what you're listening for. So normal breath sounds. So we find normal breath sounds, bronchial breath sounds are heard over the larynx and the trachea. So you see everything with the B right there. The B stands for bronchial. So those sounds are going to be harsh. They can be high pitched. They can be blowing sounds. The sound that you hear on that expiration, so when they breathe in, it's inspiration. When they breathe out, it's expiration. So those bronchial sounds are going to be longer on expiration than they are on inspiration, okay? They're going to be harsh and hollow, and they're going to be high-pitched. Bronchiovesicular, they're going to be blowing sounds, and they're going to be heard over the main stem of the bronchus. Bronchovesicular sounds are going right here. So you see that BV here, that's that, the main stem of the bronchus. If you could look in there, that's where that would be. And that's where you're going to hear those bronchovesicular sounds. And when you hear bronchovesicular sounds, they're going to be equal with inspiration and expiration. I need you guys to know what I'm telling you about these bronchovesicular sounds, okay? It's going to be on your test. Vesicular sounds are soft and low-pitched, almost whispering-like. They are heard over most of the lung fields, with sound on inspiration being longer than expiration. So see all these areas with a V? Those are your vesicular. So they are soft and low-pitched. And then it also shows you on the back as well where those areas are. So you know, if you're in this region on the back, you're going to hear softer sounds, and you're right here in the middle, your sounds are going to be very, very loud and high-pitched. So advantageous lung sounds. So I don't expect you guys to understand exactly what you're hearing. I just want you to know now, when you hear abnormal things, that it's not normal. I graduated nursing school and never heard one advantageous lung sound. I did not hear crackles in any of my patients until I actually became a nurse. And I still call nurses to my room to see if they hear what I hear, especially if I document that I hear wheezing somewhere or I hear crackles. So if I have my patient over, maybe I work 3 days in a row, and on the day 1 and day 2, I didn't hear any kind of crackles in their lungs. But then by day 3, I heard crackles in their lower bases. I would want to contact the doctor and say, you know what, I've had Mrs. Jones for 3 days and her lung sounds have been clear. Well, I just listened to the lower basses and I'm hearing some crackles. Well, maybe she's got fluid going, maybe she's got some fluid overload going on, maybe she's getting pneumonia because she hasn't been moving. These are the things you want to think about. And then you want to give that doctor a call. Well, I've had it where the doctor says, oh, I was just in the room and I listened to her, I didn't hear anything. So then I call another nurse and I'm like, can you take a listen to Mrs. Jones and tell me what you hear? It's always completely okay to have somebody else come in and take another listen. So crackles, or we also call them rails, they are fine to coarse, bubbly sounds. They do not clear when a patient coughs. They're sounds that you hear as air passes through fluid. So any kind of fluid, any just regular fluid, pus, infection, or that re-expands collapsed small airways. So what happens is all those little alveoli, they get wet, they get lots of fluid in them or pus, and then they collapse. And then when they're trying to reopen again, that's that sound of, that's all that little crackles. And that's exactly what it sounds like, is crackles. And they don't clear with coughing. So I want you guys to remember that. So you also might hear rhonchi. So rhonchi is very coarse. It's very loud. It's kind of like a low pitched rumbling. You can hear it during inspiration or expiration. This is from fluid, this is from mucus, and it clears with coughing. So if you hear these sounds, sometimes you might hear it from the hallway. You might go in and you're gonna hear, if any of you guys had kids, sometimes they're not good at getting their cough to be productive, and you can hear all this rattling in their chest. So if you are listening to your patient and you can't tell if it's rhonchi or crackles because they sound a lot alike, have them cough. If they cough and then you listen again, you would have to have them cough a couple times. If you cough and they cough and you listen again and they're gone, then you know it was rhonchi. Especially if you want to do this, make your patient do that, especially if you're going to want to go back and report something to the doctor. If you're going to call them and tell them that it's crackles or it's coarseness, they're probably going to order a chest x-ray. You know that that's coming because they're going to want to see what's going on. So you don't want to do that if they just have rhonchi. So you really want to be able to rule that out first. Wheezing sometimes can be audible from outside the room. You can hear it when you're sitting next to them. It not always is. It's a very high-pitched whistling sound as air is going through those narrowed airways or those obstructed airways. Usually louder on expiration, but they can be inspiratory or expiratory, either one. You can hear them as they're breathing in or when they're breathing out. And then pleural frictions or rub. So these are dry rubbing sounds that happens when you have that visceral area and that parietal area that is inflamed and they're rubbing against each other because there's so much swelling in there, like when they're breathing in and breathing out. And that's exactly what it sounds like. It sounds like a rubbing. Pretty easy to discern that. And if you call your doctor with any, if you call the doctor and let your doctor know that your patients have these, you should expect a chest x-ray because they're going to want to take a look. And if they're on fluids, you're probably going to stop their fluids. So we talked about, Dr. Ertwein talked this weekend about how the doctors like it when you, after you have enough experience, that you offer things to them. So if you had a patient that was getting fluids for a couple of days and you noticed that they were all of a sudden had crackles, and if you had enough experience, you would call and say, oh, hi, Dr. Johnson, I'm calling about Mrs. Jones. I've had her for 3 days now and she hasn't had any issues with breathing. And I noticed that this morning she has crackles in those lower bases. Do you want to order a chest x-ray for her? And she's still getting normal saline at 100. Do you want me to discontinue that? So really kind of anticipate what the doctor's going to do and offer that up. You want to have more autonomy in your practice. All right, so abnormal breathing. So we have tachypnea, which is when our breathing is greater than 24 breaths per minute. So you see these in oxygenation issues. When air or any other kind of issues, actually, it's a compensatory mechanism. If we're not getting enough oxygen in, our respiratory system starts working in overdrive. So we take more breaths per minute because we need to get more air in. We have bradypnea, which is less than 10 breaths per minute. So these are your patients who are not doing well, overdose patients, things like that. We have apnea, which is lack of respiration for greater than 15 seconds. So apnea, that's not a good sign. Your patient is either dying or they're dead. We have these Cheyne-Stokes. So you usually see these in your hospice patients. This is what you see when they're dying. So your respiratory pattern has no regularity at all. You have increased breathing and then periods of decreased breathing interspersed with like periods of apnea. Their breathing can be very shallow, very, very deep. As they're dying, you might think 3 or 4 times over the shift that they've died because they have this long period of where they're not breathing and you're standing at the bed and you're just looking at them. You're like, okay, this is it. Oh God, they're not breathing. Okay, they're dead. And then all of a sudden they go, and they take another breath again. It scares the heck out of you. And it can continue for a whole shift when they're actively dying. So that's Cheyne-Stokes. We have Kussmaul, which is an increased rate and depth of respirations. We see this in ketoacidosis. Usually your patients also have like this fruity odor to their breath. And then we have stridor. Stridor is a problem. If you ever hear that, your patient is having a severe respiratory problem. So you can hear that from outside the room at the nurse's station. It's a very loud, when you hear it, you'll know what it is. I've only ever heard it once. Very high pitched crow-like sound. It sounds like a screaming bird. It's associated with issues with the trachea. It could be, like it says here, a laryngospasm. If their trachea is not midline, any kind of breathing issue, and you'll know when you hear it. So if you have difficulty counting respirations during abnormal breathing periods, especially if you have these periods of apnea or their breathing is so fast-paced, or it's slow, you want to auscultate the lung sounds and you want to listen, right? You can listen for that breathing. And then you would always count for 30 seconds and then multiply it times 2. I try and stay away from doing the 15-second and do it by 30. I really want to be accurate, especially if I'm reporting some kind of abnormality to my, my doctor. And something that I see that if you work in healthcare, I'm sure you've already seen it. You will always see if patients have, not always, but it's very common that people don't measure respirations for whatever reason. They just always want to say 18, or they always want to say 20. It's common. I can't tell you how many techs I've seen do it. I can't tell you how many nurses I've seen do it, and it drives me crazy. When my uncle had COVID just a couple months ago, and I took him to my hospital, GBMC, he had a walking respiratory rate. When he walked, his respiratory rate was 42. Okay, I took him to the hospital. It was 42 when he walked. His pulse rate was 130 when he walked. When he was sitting, his breathing was 26 to 30. I knew it. I'm a nurse. I know what his respirations were. I couldn't go back with them. I couldn't get in contact with any of the nurses. I finally got in contact, and this is my hospital, and they wouldn't let me come back because they're very strict about visitors. I finally got in touch with the nurse, and I told him that he lived at home by himself and that I was very, very worried about his breathing and that he had steps to ambulate, and this is what his respirations were. Well, they didn't keep him. They did a chest x-ray and said he had a mild case of pneumonia, sent him home. When I got his paperwork at home, it said his respirations were 18. I was livid. His respirations were not 18. And I see this all the time when I go in and I look at my patient's vitals in the morning, and then I get to their room and their vitals are the opposite. Vitals are so important. They are their first sign that you get that your patient is decompensating or they're declining somehow. And it's not, I know it can seem very task driven, but it's extremely important that you always take the time to count those respirations and make sure that you're documenting them correctly. And if you have an issue with a patient that has oxygen or an issue with a patient that is having some kind of breathing issues, go behind that tech and make sure that those respirations are appropriate. All right, a question. When the client with a head injury arrives in the emergency room, which of the following considerations should receive the highest priority? Establishing an airway, replacing blood loss, stopping bleeding from open wounds, and determining whether the patient has a neck fracture.
A.
A.
Why do you think A?
D.
Me, I would say because if he doesn't have an airway, he's not going to be alive for much longer.
Exactly, ABC. So some people might have wanted to say that neck fracture because he had a neck injury, a head injury. ABC, airway, breathing, circulation. Those are always going to,
Oh, gotcha. Oh,
don't let those things distract you, okay? ABCs. What's wrong, Dina?
I left myself unmuted like an idiot. I'm so sorry, class.
Oh, I didn't hear anything. Did you do something good? Something to really be embarrassed about? No? Okay. The nurse in the post-anesthesia care unit is monitoring several patients who receive general anesthesia. Which patient adaptation causes the most concern? So a patient with pain, stridor, lethargy, or diaphoresis?
B.
B.
Why? Why is it B?
That would mean that the breathing is not
Who said
normal.
that? Yes, who's saying that?
Sophia. Sophia.
Very good, Sophia. It has to do with the airway. So these other things are important, right? They just had surgery. We want to monitor their pain. They could be tired, but lethargy is pretty common if you have general anesthesia. Sweating, okay, they might have a fever, but if they have stridor, their airway is compromised. So that is your priority. Very good. A client develops dyspnea, tachypnea. Hold on a second. Can you hear my ignorant husband again who's just screaming through the house? Hold on. I mean, I can't with him. It's like he knows I'm up here teaching and he's just screaming his head off. I go, I'm sorry. I swear to God. But my granddaughter has to get stitches, so I guess it was kind of important, but whatever. He's still men. All right, a client suddenly develops dyspnea, tachypnea, and chest discomfort. What should the nurse do first? So you just come in the room, your patient's short of breath, their breathing is 24, okay? They're having some chest discomfort. First of all, I want to know what you guys think is going on with this patient. What kind of problem? What do you think is causing this?
A heart attack, maybe.
Very good. Exactly. That's what I would think. What should we do first? Do we want to call the doctor? Do we want to encourage the client to cough and deep breathe? Do we want to listen to those lung sounds and see if we hear anything abnormal? Or do we want to elevate the head of the bed 30 to 45 degrees?
D.
Elevate the head.
B.
Elevate the degree. Elevate the H. Yeah. D.
Elevate the head of the bed. You got it. That's the first thing you're going to do. Why do you think you're going to do that?
Ortho.
To be able to breathe.
Cavity there's more room in the cavity for the lungs to expand. So you
got
need to
it.
do that. And I think I have the physician on the phone as I was doing it.
So when you guys are in clinical and you walk in and you do vitals on your patient, you're going to have to do pulse oxes with the machine. Everything else is going to be manual, but you obviously can't do a manual pulse ox. So you're going to use that machine. If you get readings of 89, 90, 92, 94, before you go out and get your instructor, I want you guys to, because when you go out and get her, they're going to want to know what you've done to implement any kind of things to see what's going on. So the first thing you're going to do, elevate the head of the bed. Your client's been sleeping all night. Depending on how old they are, it's long-term care, they're sick or they're old. So their lung issues. They probably have lung issues just from aging, if not from some kind of a disease process. So sit the head of the bed up. Usually 95% of the time that makes their oxygen go right up. If it doesn't, while the pulse ox is on, have them take 3 deep breaths. Usually that's all it takes. If they're a little more compromised and they have an incentive spirometer there, you can have them do 1 round of that incentive spirometer, and 9 times out of the 10, that oxygen pops right up. If it doesn't, then you're going to want to go get your nursing instructor. But if that does happen, then you're going to go to your nursing instructor and say, hey, I wanted to let you know I went in to see Mrs. Jones. When I first did her oxygen, it was 92. I put the head of the bed up. I had her take 3 deep breaths. She's still pretty low, around 92, and she's not on any oxygen. I think we should put her on some oxygen. Can you come with me? Okay. So that's how you guys should be communicating with your clinical instructors, if you ever get into clinical. All right, so we're getting ready to start perfusion. We are a little bit more than halfway through. Do you guys want to take like a 5-minute break?
Yes, please.
Yes.
Okay, let's come back in we'll take like 6 or 7 minutes, okay?
Sounds good. Thank you.
Okay. All right. So perfusion. Perfusion, the definition is the exchange of blood, gases, and fluids between vessels and tissues and organ systems. So cardiovascular and peripheral vascular assessments include assessments of the heart and the extremities. So questions that we can ask in that health history that can identify subjective data such as leg pain, if they have any chest pain, any dyspnea. What's dyspnea? Amy.
Breathing pain when you're not you're breathing with an issue.
Dyspnea is shortness of breath. So when we say dyspnea, it's shortness of breath. Okay.
Shortness of breath, yes.
Yes, shortness of breath. So if your patients say, I have leg pain, I have chest pain, I have shortness of breath, you can look at certain health behaviors that would increase their risk of cardiovascular disease. So are they overweight? Are they diabetic? Do they smoke cigarettes? Do they not exercise? Do they consume a diet that's very high in calories, high in fats, and a lot of salt? These are all contributing factors to cardiovascular disease. Again, that's why that health assessment is so important, because we are identifying issues and preventing issues. So when we're looking at perfusion issues, we're going to inspect. So again, we're going to look at our patient's color. Is their skin pale? Is it cyanotic? Is it mottled? So sometimes when patients are actively dying, their lower extremities get what we call mottled. So it's just like little bits of redness all over and little like areas of paleness. That's very common. As the heart slows down, that good perfusion is not getting all the way down to the lower extremities. So that's when you see that mottled. Are those buccal membranes inside the mouth nice and bright pink? Are they pale? Moisture, is the patient moist or the patient dry? Are they cool or are they warm? Do they have that JVD, that jugular vein distension? So questions that you would want to ask, are you having any chest pain? You would want to ask them, do they have any edema? Because if they have edema at home, normally if they say, yeah, you know, my feet have been swollen for about a week now. At the end of the day, I don't fit in my shoes anymore. Well, if that heart is not pumping effectively, then you're going to get all that pulling of the blood in those lower extremities and you're going to get edema. Are they dizzy? Maybe they have hypotension. Or orthostatic hypotension. Are they fatigued? Fatigue can be a major sign of a heart attack in some people. What's their skin color look like? What are their pulses? Are they absent? Do they not have any? that would be a problem. If they don't have any pulses anywhere, that would mean that they're probably dead or they are dying. If they've had a surgery, a knee replacement, you would want to make sure that you could feel those pulses behind the knee. You would want to make sure you could feel those femoral pulses, those the pulses in the feet. You want to make sure that there's good blood flow to all the peripheral body parts. Is the pulse weak? You can feel it, but it's very weak. Is it thready? So it's not very strong. Excuse me, it's kind of sporadic. Is it forceful or bounding, really strong? So if it's forceful and like really bounding, it could be that they have fluid overload, or it could just be, sometimes that's just normal for people. And is there an asymmetric pulse? Do you have that pulse deficit? So if I'm feeling both wrists and this pulse, the right arm pulse is weaker than the left, then we know that there's an issue. We have a pulse deficit. They're not normal. So some subjective data. You want to find out, do they have a history of any heart trouble, pre-existing diabetes? Do they have any heart history in their family, cardiac history? Did anybody before the age of 42 is in their family have a heart attack? Their parents or grandparents, sisters or brothers. Issues with lung disease. Have they had issues in the past with obesity? If they're not obese sitting in front of you. Hypertension, do they have high cholesterol? Do they have any chest pain? If they say yes, when? So they might say, well, sometimes when I'm going up and down the driveway with the lawnmower. So that is a sign of, that can be angina. So when people get chest pain when they're doing exertional things, it can mean that they have blockages somewhere. And then when they're doing things that cause stress on their body, that's when they have the chest pain. You would want to inquire even further from that. Like how long does it last? How often does it happen? Can you describe the pain? And then does it radiate anywhere else? So can you feel it in your arms, your neck, or your jaw? So people that are having heart attacks, some people say that they have that chest pain that goes under their arm. They have chest pain that goes up into their neck. It can go around behind their shoulder. It can be felt in their jaw. So really get them to describe that pain. And then you want to know, what have they tried to relieve the pain? And if what they took, if they took Tylenol, does it work? Or do they take a narcotic, and is it helpful? Describe their energy level. So that's going to give you some information about if they participate in exercise and how sedentary they are. Do they frequently feel tired? Are they more fatigued than usual? Do they have a history of smoking, drinking alcohol, using caffeine, or prescriptive or recreational drugs? Those are all questions that you can ask them to assess their perfusion. So we have a lot of places where we can palpate our pulses. So we have the carotid arteries, one on each side. We never, ever, ever do them both at the same time because the patient will pass out. We can do one at a time. We have our brachial artery. We use this when do we palpate that brachial artery? We've already done it in skills.
Assessing BP.
Yeah. Very good. Then we have your radial and your ulnar pulses, and we've been doing that. You have the femoral pulses, popliteal that's right behind the knee, and then you have that posterior tibial and the dorsalis pedis. So you are going to make sure when you're palpating, you want to see if it's regular or irregular. You'll know if it's irregular because it won't feel regular. You know what regular is. You can feel it. It has a constant beat. It's regular. If it's wishy-washy all over the place, fast, and then slow, that's irregular. If a patient has AFib, it's going to be hard for you to feel their pulse. You're going to feel it, but you're going to know right away that it's irregular. Is it very, very, very fast, or is it extremely slow, or is it normal? How does it feel? Is it bounding against your fingers? Is it very, very weak, like you can barely feel it? Does it feel thready? Does it feel normal, or is it absent? So maybe you're going to have a patient that goes off the floor. He might have a procedure. You have that patient that had that left knee replacement. You're going to want to monitor those patients, those pulses above and below the knee, because you want to detect a pulse deficit. You want to make sure that there are pulses above the knee, so that you know that there's no issues there. And then you also want to check either the dorsalis pedis or the posterior tibial, because you want to make sure that there's getting blood flow from the procedure site down, so down and up. If you notice a pulse deficit, it is an important situation. You could lose a limb if they don't get proper blood flow to a certain body part. So you would want to make sure that you report that finding to your physician, okay? You want to call the doctor immediately. That's an important slide. Okay, you want to know that. Our nurse is checking the vital signs of a 92-year-old client. The radial pulse has an irregular beat about every 5th or 6th beat. The rate is 92. The client is asymptomatic. The nurse's next step should be. So let's look at that question before we look at the answer. So she's 92. That's fine. She's old. Her pulse is irregular. So we know that that's not normal. Okay. Irregular is not normal. What do we know about the rate? Is her rate normal or abnormal?
It's within normal limits.
It's within normal limits. So it's irregular. The rate is normal. And it says the client is asymptomatic. Okay. You want to pay attention to all three of those things. Now it says the nurse's step should be 2. Are you going to call the doctor immediately and let them know because it's irregular? Are you going to place them on a telemetry monitor so that you can monitor their heart? Would you obtain an EKG? Or would you check an apical pulse for 60 seconds and note any pulse deficits?
D.
Does anybody
D?
see anything different than D? Good. You said B? So you could. So,
D is,
oh, okay. So the answer is D.
yeah,
Very-
initially I did. Yeah, I did.
Okay. Yes, it is D. So this is not abnormal. You would just treat the patient. This can be a number of your patients. It could be all 5 of your patients that you're taking care of that day. This is normal findings in older people or people that have health issues. The patient's not, experiencing anything symptomatic. The rate is completely normal. So you would just want to make sure you get that apical pulse, which is going to be the most accurate, check it for an entire minute, and then note any pulse deficits between that pulse and the apical, because then you know that something's going on there if there's a pulse deficit. There's a pulse deficit, then you're going to call the doctor. But you want to have all your information first, because that's what he's going to say to you when he calls. What did you check? Did you do an apical pulse? No, let me run back and do that and then call you. So you got to try and think and try and know what the doctor's going to ask you for. So your capillary refill, it should be less than 3 seconds. That is normal. You're going to check your hands and your feet. So you can see right there, they're checking the fingers. Prolonged capillary refill is associated with alterations in your peripheral perfusion and your cardiac output. If I told you earlier, if they have nail polish on, you can check the back of their fingers. Same thing with the back of their toes, especially with older people, because their toes are a hot mess and you are not going to be able to see anything. They're thick, they're yellow, green, black. They're just gross. So you're going to have to check the back of their foot. Can you tell I hate feet? I hate feet. You want to be very careful and make sure you're checking those pulses on patients that have casts, right? Anything, any kind of restraint, if your patient's in restraint, if they have any knee immobilizers or shoulder casts or immobilizers, anything like that, because you're going to want to make sure you're checking that circulation, because these things could be on too tight and they could impair their circulation. You want to look at that skin and make sure that it's pink instead of white or blue, because that means they're not getting a lot of blood flow. You want to make sure you're checking out any kind of excessive pain that they're screaming of, especially these surgical patients or these patients that have casts or that are in restraints. And then any circulation greater than 3 seconds. Or if you see one extremity that's warm and another one's cold. Those are not normal signs that you would see. That would make you think, what's going on with my patient? So the PMI is the point of maximum intensity. It is the mid-clavicular line, fifth intercostal space. I want you guys to memorize that. You're going to see it again. It's very important. It is the apex of the heart. If I tell you that you're going to go do an apical pulse on a patient, I want you to be able to tell me where you can find it. It's mid-clavicular, okay? So clavicle area, mid-clavicular. You go down to the fifth intercostal space. You'll use your finger pads to palpate in between. If you do it on yourself, you can feel those intercostal spaces. And you would get to the fifth one. That is the apex of the heart. It is very hard to do on a woman. You're going to want to die if your instructor tells you to do it on a woman, because you're going to have to go in and pull her boobs up. And a lot of people don't like to do that. I was terrified to do that, but it's the only way that you can do it. You have to lift the girls up and really get in there. Men, it's much easier, obviously. So let's see. Mid-clavicular line, fifth intercostal space. Guys got that, right? So these are our heart sounds. So auscultating is used to determine the heart sounds that we hear, and we hear those sounds based upon the opening and closing of those heart valves. So one good way for you to think about what areas that you're listening to where the heart valves are, it's called all people, what do they say? It's all people eat taco meat. So it's pulmonic, mitral, tricuspid, and aortic. That's how some people remember it. I didn't remember it that way, but some
I
people
was
say.
about to say, I learned all patients take meds.
Ooh, I like that better. All patients take meds. Yes, let's use that. All patients take meds. That's very good, because really not all people take taco meat. So, all right. So you want to use you want to develop like a system for how you're listening to them. So you want to begin at the aortic area. Then you're going to listen there. Then you're going to move to the pulmonic area, and then to the Erb's point, which you don't really see. There's another slide on here that shows you where that is. Then you're going to move back over to that tricuspid area, and then finally over to the mitral area. So you're going from left to right and left to right, okay? Abnormal findings when you're listening would include extra heart sounds at any of those cardiac landmarks where you're listening, an abnormal rate, an abnormal rhythm. Patients that have extra heart sounds when they have cardiac disease, if they have fluid overload, sometimes patients with anemia have it. Extra heart sounds, we call those, depending on where they are. So you could have an S3 or an S4 or a murmur. So an S3 is known as the third heart sound. It follows your S2. So it's what they say is lub dub. Lub dub is your normal. Lub dub, lub dub, lub dub. That's how we say your S1 and your S2. Okay, that's what you want to hear. That is a completely normal finding. You want to hear that in every one of your patients. If you have an S3, which comes after that S2, the dub, lub is the S1, dub is the S2, and then it would sound like lub dub D, lub dub D. That would be an S3, okay? They say that the best way to hear that is using the bell of the stethoscope at the mitral area when your patient is laying on the left side. I've never done that with my patient. I've never heard an S3, and I've never heard an S4 either, but I've heard a lot of murmurs. S3 is very normal in children and young adults. Middle-aged people and older adults, it's not normal. A variety of different things can cause that too. We won't get into all that. I don't expect you to know all that. S4 is the fourth heart sound. It occurs right before your S1. And they say So it's just the opposite of the lub dub D. It's D lub dub, D lub dub. And you'll be able to, we have some abnormal sounds that you guys are going to be able to listen to with the stethoscope this weekend, which is really fun. And
Mrs. Davis, not to cut you, I'm sorry. Can you just click on the next slide so that I can like write down? Are you doing the lub dub, the S1 and S2?
oh yeah, I'm going to go to
Right
that
now?
one. Oh no.
Oh, okay. I thought you were already there.
Oh no, I haven't gone there yet. So the S4 is the D lub dub, D lub dub. It is, now this one is normal in older adults, but not normal in children and younger adults. So it's the complete opposite of the S3. And then heart murmurs, those are those extra sounds that there's some kind of disruption with the blood flow in the heart, and they sound like swishing. And that's exactly what it sounds like. You really can't really hear that lub dub too much. It's just a swooshing. So when you're listening, that S1, that is your lub. Lub is the close of the mitral and the tricuspid valves. It's best heard over the apex of the heart, and it corresponds to your carotid pulse. So so the mitral and the tricuspid valves, let's just go back. Where are they? So we said here is the tricuspid valve and here's the mitral valve, right? These are close to the apex of the heart. And let's just count here. 1, 2, 3, 4, 5. There's that fifth intercostal space, right? We're at the apex of the heart. And right here is those tricuspid and mitral valves. So they are right in that area. And when those valves are closing, that's when you're hearing that lub. The dub is closure of the aortic and the pulmonic valves, best heard over the base of the heart border. So if you know where these are, you know exactly where to listen. So you guys need to be familiar with this. S3 is always going to follow S2. That makes sense, right? 3 comes after 2. That's due to rapid blood flow. And then S4 is going to be heard before S1. And that is just, there's a lot of different things that cause that. We won't go into that. So then Erb's point, I told you that is the third intercostal space. This is a cute little diagram here. And then this just shows you what it does here, the lub dub and what's closing and what's opening. So oscillatory sites for the heart. So the aortic, when you want to listen to the aortic area, you're going to listen just to the right of the sternum at the second intercostal space. And when we do right and left, we are actually looking, it's us looking at the patient, okay? Oops, hold on, my stuff's not moving. When we're actually looking at the patient, we are still gonna, I said that the wrong way. We are going to think of it as their side. It's easy for us to get confused because when we're looking at them, it's on our right or left, but we need to think of it of where it is in relationship to them. So if we're looking at the patient, it's going to be on the left side because it's on their right side. So that's the aortic valve. Then the pulmonic is going to be just left of the second intercostal space. You have the Erb's point, which is just left of the sternum at that fourth intercostal space. If you want to listen to the tricuspid area, you would move to the left of the sternum at the fourth intercostal space. And then you have that apical and that mitral area, left midclavicular at the fifth intercostal space. All patients take meds. That's a good one. I like that. All right, so, and the purpose of listening to those is so that you could identify any kind of abnormalities. You could hear a murmur over here, but not over here, things like that. And you really want to take your time and listen. These are very thorough assessments that you want to do. It always cracks me up when I go to the doctors and they put their stethoscope on me and it's like, boom, boom, but they're not really listening. So you always don't be that nurse. Just be very thorough and really listen to your patients, because it's sometimes you might find something that they didn't know was there that could save their life. It's an important assessment skill. So murmurs, they are a reflection of what we said, that turbulent blood flow from when it's going through the valves. It is a gentle blowing. It's not always gentle. Sometimes it's very loud, and it's definitely a swooshing sound. So if you have a high velocity of blood, if the viscosity of your blood decreases, you might hear it. If you have any kind of defect in the valves and any unusual openings that occur in the chambers. All right, so female reproductive. So what are we going to document about our female patients? So we want to know, this is probably not for the hospital setting, but definitely in your primary care office, you would want to know how old they were when they got their period. And this is pretty focused. So you would probably be working in an OBGYN office if you were asking all these. I do ask my patients now when they come in, when their last menstrual period was, if they still get one, because we do want to know that, especially if they're going to have certain tests that we wouldn't want to do if they're pregnant. We want to know when they've had their period and if there's a chance they could be pregnant. But these are pretty focused and would be in a primary care setting. So the age when they started their menses, what is their current menstrual cycle like? Does it last for 28 days? Do they not get one at all because they take birth control pills? Is it very heavy for 12 days? What's their pattern? Or are they in menopause now? You want to ask your patients if they are doing breast self-examinations, and then you want to educate them about the importance of early detection and doing those every single month. If you are educating them, make sure you tell them to do them monthly after their menstruation, usually 2 to 3 days after, because when you're getting your period, it's very common at certain times that you find little tiny lumps and bumps in there that are not normally there. And that can be very frightening. So usually a couple days after your period has ended, you want to make sure that they're making sure that there's no drainage coming from their nipples. They don't have any indurations or any dimpling. That can be a sign of certain breast cancers, because the tumors grow and they start to pull on that skin. So you would want to look at the breast and then those lymphatic areas that are around it. So you can see when we hear patients talk about they had breast cancer and they had to check the lymph node tissue. So you can see all these in this right picture here, all these lymph nodes that run up through the neck, up through the arm, and through the breast. So if they have breast cancer right there, it's very easy for that breast cancer to move and go into those lymph nodes. So that's usually why they take some of those lymph nodes out, because they want to see how far it spread, if it has spread. So you want to inspect the patient. You want to have the patient sit at the edge of the bed or very high, like in a high Fowler, up in the bed, raise their arms up overhead, push their hands on their hips and lean forward. You can look at their supraclavicular area, their infraclavicular area. You can palpate under their arm, check for any swollen lymph nodes. If you are going to do a breast exam on the patient, it's best to have them in a supine position. You can have their arms up over their head, palpate the breast tissue, including that little, what they call the tail of Spence, because even though it is higher up on the chest, it is considered part of the breast tissue. Make sure you're examining the nipples very good, the areola, and then teach those women to do those self-breast exams. They are extremely important. So assessing the abdomen. The abdomen, this is the intake and use of nutrients by the body. So there's all your little body parts, your spleen, your stomach. See how the rib cage protects all that important area. You have your ascending colon, your appendix is in there, that little tiny thing right there. Something so little can cause so much trouble. You have your bladder at the bottom, you have your descending colon, your sigmoid colon, all that good stuff. So when you are talking to these patients, you are going to want to ask these questions. Do you have any nausea? Do you have any vomiting or cramping? So again, keeping in mind, if you have a patient that came in because they had a knee replacement, you might not ask all these questions because it's not really part of that focused assessment for them. If you had a patient that came in with a bowel obstruction, then absolutely you're going to ask all these questions because it would be appropriate. So do you have nausea, vomiting, or cramping? Have you had any change in your appetite lately? Are you able to tolerate your diet? Are you experiencing issues with food intolerance? Have you had any weight changes? You want to be able to look at them and, you want to know, say, yes, I'm having vomiting, I'm not eating. Is this impacting them from a nutritional standpoint? Because now they're losing weight. Do they have any difficulty swallowing? Is it that they can't tolerate their diet or they just can't even get their food down? After they eat, do they have a lot of periods of belching, gas, or bloating? Have they noticed any blood in their stool, any blood if they've been vomiting? What's their bowel patterns like? When was your last bowel movement? If you have a patient that comes in with a small bowel obstruction and they're not going to the bathroom, that is going to be the first question you ask them. That is the most important thing you want to know. Well, when was your last bowel movement? And that's important information. I want you guys to remember that. What are your normal bowel habits like? Do you have IBS and maybe you have diarrhea every day? Are you chronically constipated? Do you have to take stool softeners every day? Do you have to use enemas or laxatives? Do you have black stool? So if you have black or tarry stool, that is a sign of an old GI bleed because the blood is dark. Bright red is an active bleed. And does anyone in your family have a history of colon cancer? Because that's going to determine what kind of recommendations you make for them as far as screenings. So you're going to make sure you ask if they had any abdominal pain, any history of indigestion, nausea or vomiting, food allergies, lactose intolerance, what's their appetite normally like, and then those bladder and bowel patterns. Do they have a history of any GI disorders? Maybe they have IBS or IBD. Do they get a lot of urinary tract infections, or do they have any other urinary tract issues? Have they had any abdominal surgery or any trauma? A lot of people that come in that have abdominal pain, sometimes they've had a lot of different abdominal surgeries and they get adhesions in their abdomen. And they have pain for almost, it seems like the rest of their life. And it's something you really can't take care of unless you go in there and like scrape everything out. And then for women, you want to know their menstruation history. And then you want to know the amount and type of alcohol ingestion that they take. So when we inspect the abdomen, we want to see if it's distended. You want to look and see if there are any scars. Are there any masses? Do they have any ostomies? Any striae? Any kind of like damage to the outside of the skin area? What shape is it? Is it flat? Is it rounded? Is it protuberant? So this is very important, you guys are going to see this again, you need to know the order of your abdominal assessment. So you always, always, always want to inspect first. Inspect comes first, then you auscultate, then you percuss if you do percuss, and then you palpate. That is the last thing that you do. If you palpate before you auscultate, you're moving things around. Before you're able to listen, okay? So that's why it's so important that you listen first before you palpate. You're gonna see that again. So we divide our abdomen into 4 different quadrants. We have the right upper quadrant, the left upper quadrant, the right lower quadrant, and then the left lower quadrant. So when you listen to bowel sounds, you're gonna start down there at that right lower quadrant, and then you are gonna move up to the right upper, then you're gonna move over to the left upper, and then you're gonna move over to the left lower. Do you guys know why you start at the right lower?
That's where the colon starts.
The liver.
Yeah, so
I
that's
think
where
it's due
you're,
to like the short intestines.
yes, that's where your ascending colon is. So you're going to do that and then follow it all the way over. You got it. So we inspect first before we palpate, and then we listen in all 4 areas, right lower, right upper, left lower. When we're listening to bowel sounds, less than 5 per minute is going to be hypoactive. A bowel sound is pretty similar to what you hear when your stomach growls or you've heard your stomach rumble. I'm sure we've all heard our stomach rumble. Those are bowel sounds. It's very common to hear active bowel sounds in patients that have been NPO. They haven't been eating. If they have blockages and they're not going to the bathroom, well, there's nothing moving around, so you're not going to have any bowel sounds. Your patients that have diarrhea, they're going to be hyperactive because they're going to have a lot of action going on down there. So when you're listening, greater than 30 per minute is going to be considered hyperactive, and that's how you're going to document your bowel sounds when you're documenting. So you're going to document, did they have any? Did they have them in all 4 quadrants? And then were they hypoactive or hyperactive or normal? So if you don't hear any bowel sounds, in order for you to be able to say that you didn't hear any, you have to listen for 5 minutes before declaring that there is no bowel sounds. And no bowel sounds is a problem. Usually this will happen sometimes with small bowel obstructions, and usually they have to go in and do surgery. So 5 minutes you have to listen. That's a long time to listen and not hear anything. I've never actually done that. You want to note any sounds that you hear, anything that sounds abnormal. Let's see. Bowel sounds, like if a patient has abdominal surgery, it is common at first because everything goes to sleep, everything. So the patient goes to sleep and all their body parts go to sleep. So it is pretty common that those bowel sounds will be decreased at first, but they should start to come back. Again, if they haven't been eating, they might not have many bowel sounds. So when you're looking at the patient again, this just shows you the areas where you could palpate for things. So you see off to the left, there's that spleen. If you had a patient that had cirrhosis of the liver, or they were an alcoholic or had some kind of liver issue, you might notice that that liver is swollen. You will be able to feel it. And then you see where your colon would be. So you have your ascending colon up to your transverse colon, and then down to your descending colon. So percussing the abdomen, we don't percuss, but if you were, you would expect dullness over that liver or that distended bladder. You would expect to hear tympany over the most of the abdomen, and then a lower pitch tympany over the gastric bubble in the left upper quadrant is usually common. You would want to percuss all 4 quadrants, and then you would want to percuss over the borders of that liver and that spleen. But we don't do that, so you guys don't have to worry about that. So palpating the abdomen. When you're palpating, you only want to go about a half of an inch to an inch. You don't want to press really, really far in. You should expect to feel softness. It should be kind of mushy. There should not be any nodules or masses, and the patient would not be guarding. And by guarding, we mean they're holding over, they're holding their stomach, they might be rocking back and forth, they might wince when you touch it. You want to lightly palpate in all 4 quadrants. And then you want to palpate to see if you can feel that liver, the spleen, and the kidneys. And then you do want to make sure that when you're moving, you want to start at the right, the bottom right, just like you did when you're listening. And then you're going to be monitoring your patient's responses. So are they, wincing? Are they shaking? Are they jumping when you touch a certain area? You can ask them when you're doing it, is this tender? Is this tender? Do you feel anything here? If the patient experiences any kind of spasms, If you feel any rigidity in their abdomen, or if you can feel it spasming, this could be, I mean, it could be anything. It could be an infection. They could have peritonitis. They could have had some kind of trauma. Any of the organs could be enlarged. They could have tumors. It's very, very hard to diagnose things that are going on in the abdomen. It can be so many different things. So elimination is the removal of fluids and wastes from the body. All right, so questions. When was your last bowel movement? What's the consistency? So if you know your patient went to the bathroom, I always say, did you have a bowel movement? When was your last bowel movement? Oh, it was this morning. Okay, well, how was it? Was it normal? Yes, it was normal. And then if they say, well, what's normal? Well, does it have any blood, pus? Was it loose? Were you constipated? Those are abnormal things. Is it a normal pattern? Do they go every day? Do they only go every 3 days? Do they have any pain or discomfort when they went to the bathroom? Do they have any bleeding, or do they have any abnormal gas? Abnormal things are constipation or diarrhea, depending. If you have a patient that has IBS, diarrhea is an abnormal finding, but it is normal for someone with IBS. They live with diarrhea, especially if they don't take medicine for it. And they could have a fecal impaction if they are constipated. And if they have a fecal impaction, do you know what you guys can do to help them with their fecal impaction? Go ahead. A what? What did you say, Dina?
Digital insertion.
Digital removal. I see Heather laughing. Have you done a digital removal, Heather? No. Yeah, that is in our scope of practice. Whether you want it to be or not, it is in our scope of practice. So when you're looking at stool, there's a nice little picture there. And they even give examples. So the first shape is hard, little balls, hard to pass. That means it spent too much time in the colon. They compare that to little Bristol balls. Then you have the lumpy fecal balls that are stuck together. That looks like monkey bread. And then you have the third one, which is like sausage with cracks in it. Yeah, cracked sausage. Then you have Goldilocks pool, which is like a banana. Soft and moist, not too hard, not too soft, just right. Then number 5 is typical with several stools a day. The 6th one is what you would see, could be signs of stress or IBS. They call that fluffy poo. And then diarrhea, which is not good. Fountain of poo. It's great. Be a nurse, they said. It'll be fun. At my job, we have these boards. We have these, and they compare them to like Milk Duds and Yoo-Hoos. And I'm like, God, why do you got to do that? You're ruining it. You're ruining it for me. All right. So when we're looking at urinary elimination, we want to remember that the very first urine of the day is much more concentrated than any other urine that's excreted during the day, because it's not fresh. It's been accumulating inside of our body for hours. So the urine may be good for certain tests, like for a pregnancy test, it's great to do the first urine. Other tests, not so much. So you just want to know what criteria you need to meet for certain specimens. The frequency that a person urinates depends on the amount of urine that they're producing. So the amount of urine that they produce depends on the function of their kidneys. The more urine produced, the more often you're going to void. If you're getting a lot of fluids, you know you're going to be voiding a lot. If you're giving your patient Lasix, you know they're going to go to the bathroom a lot, because we give Lasix to pull fluid off. So it's going to make them urinate. People who don't urinate very frequently develop more UTIs and kidney disorders than people who go to the bathroom like every 3 or 4 hours. It's just proven because of the stagnation of the urine inside the bladder. It's just sitting there for so long, and that it's a great medium for bacteria to grow. And nurses are one of those people who develop UTIs and kidney disorders more than other people, because it's hard for us to go pee sometimes we're at work. 10 or 12 hours goes by and you haven't even gone to the bathroom. So you want to ask these questions to your patient. Do you have any burning or pain when you pee? Do you have any itching? Do you have any urgency or frequency issues? So I don't usually ask that with my younger. I ask everybody, when was your last bowel movement and do you have any burning or pain when you pee? I don't care how old you are, that's what I ask. I don't usually ask urgency or frequency unless it's an middle age to older person. I'm assuming that a 20-year-old doesn't usually have those issues. But if I see it's an older person, I'm like, because that's one of the criteria for assessing them to see if they're at risk for falls. Because if they're urinating frequently or they're having to go urgently, they're going to be getting up out of bed a lot more and they're going to be jumping out of bed. And if they're of high fall risk, then we want to try and prevent that. And then I would only ask them if they had any blood in the urine if they were there for a UTI, or I thought she had symptoms of a UTI or something else that would indicate to me that something was going on. So the minimum output that you want from your patient is 30 mLs per hour. So if you've been taking care of your patient from 7 o'clock in the morning and it's 3 o'clock in the afternoon, that's 8 hours, right? 8 hours. And your patient put out 400 mLs. Before you give shift change report, you want to know, was that enough urine for my patient? So you take that 400 mLs, you divide it by 8 hours, 50 cc's. That's normal. The minimum output is 30 mLs per hour. Okay, so yes, that is an appropriate amount. It might not be as much as you or I would pee, but it is an appropriate amount. Then you want to see if they are continent or incontinent, because then again, that we're looking at their skin, right? If they're constantly stooling or urinating on themselves, they're going to get skin issues. And then when you look at that urine, you want to look at the color. You want to look at the clarity. So what color is it? Is it a nice pale straw color? Is it dark orange? Does it look like soda? Sometimes patients that have rhabdomyolysis, it'll look like pure soda. It looked like Coke. What clarity is it? Does it have flecks of blood in it? Does it have sediment in it? Is it really, really hazy? You can't see through it. What kind of an odor does it have? And any sediment. Bladder palpitate. So you could, when you're palpating the bladder, you should not be able to palpate someone's bladder after they went to the bathroom because it goes down to very small. If you have a patient that is retaining urine and they're distended, you will know. Like I've had patients where they say, I can't pee, I haven't peed, and I pull back the cover and their abdomen is just distended. And if that's what's going on, you want to go right away and get a bladder scan and scan your patient. Because if they are retaining, their bladder can rupture and that could kill them. Strict eyes and nose are very, very important. So if your patient has strict eyes and nose, you want to make sure that if they have a Foley, you're checking it every 4 hours. You want to make sure that for men, they have a urinal that has numbers on it so you can measure. For patients that get up and walk in the bathroom, you want to make sure you put one of those hats in the toilet that have the measurements inside so that when they pee in it, you can measure it. Make sure you tell them to keep it and call you when they pee so you can go in and take a look at it and you can measure it. And then just make sure you're always telling them to put the toilet paper in the toilet behind them, not in their little container, because that soaks up some of the volume of the urine and it won't be an accurate measurement. All right, what should the nurse monitor to assess a patient's renal perfusion? So what is renal perfusion?
Kidney.
Kidneys.
It's kidneys. What is perfusion? What is renal perfusion going to tell us about our kidneys?
Whether they're working or not.
If the blood is circulating to it.
Yes. If there's no blood circulating, if your kidneys are not being perfused, and by perfused, we mean is there blood getting to them? If there's no blood getting to them or it's a decreased amount of blood getting to them, then they cannot function properly. So in order for you so when I say you're assessing a patient's renal perfusion, we want to know if their kidneys are working. So would we want to monitor, if we monitor their blood pressure every 15 minutes, is that going to tell us if their kidneys are being perfused? If we check their urine.
No.
Okay. If we check their urinary output, is that going to tell us?
Yes.
Yes, so that's true. Would we want to monitor their body weight every day?
No.
No.
And then if we do I&Os every 24 hours, is that going to tell us?
It could tell you, but it won't tell you enough.
Exactly. That's how I want you to think. That's how I want you guys to answer these questions. Yeah, I's and O's would be good, but we want to know right now. So we want to do that urinary output every hour, because if we're measuring that and it's a good amount, then we know that they're working. All right, so a female genitalia exam. Again, very specialized, usually if you work at a GYN clinic, or you might assist a GYN doctor do this in the hospital, but you won't be doing it. So you would just want to make sure you're inspecting the external area very well. You would palpate the labia. You're going to use a vaginal speculum. You would use that inserted into the vagina to look at the cervix and other areas inside the vagina. You could obtain specimens like a pap smear to send off for cytology. You could do bimanual exams of the cervix, the uterus. I'm not going to test you guys on this. You also could examine the rectum to make sure that there's not, you don't feel any kind of masses in there. And then you could send off stool for occult blood. And then for the men, you would want to inspect and palpate the penis. You would want to inspect and also palpate the scrotum. You would want to check and see if there's any masses in there. You could palpate up to see if they have any type of inguinal hernia. I wouldn't even recognize what that was. I've never done that before. And then you could palpate the inguinal lymph nodes. So the anus, the rectum, and the prostate exam, you would inspect the anus and the perianal area. You would inspect them bearing down, doing that Valsalva maneuver to see if you feel any masses or anything in there. You would palpate the anal canal and the rectum on all adults. I've never done that. And you could send off blood samples, stool samples, obviously, and test for occult blood. So blood in the stool is a sign of, it could be a sign of colon cancer. So assessing the musculoskeletal system, this is the movement and engagement in physical activities. So questions that we want to ask them, what is the that we want to look at is what is the activity order for our patient? So if you get a new patient to the floor, what's their activity order? Do they want them out of bed 3 times a day? Do they have up ad lib, which means they can get up as they please, or are they on bed rest? Do they have any restrictions? Do they just have surgery and maybe they're non-weight bearing on one of their extremities? Do they have any pain when they move? Do they have any difficulty ambulating? Are you able to care for yourself at home? Have you had any falls? I ask that every day. Have you had any falls in the last 6 months? It's part of your fall risk assessment. You want to know. What do you use at home to ambulate? Do you use a cane? Do you use a walker? Do you need any of those while you're here? Let me see if I can get some for you. Do they have any contractures? Do they have any abnormalities, any kind of foot drop? Are they missing any extremities? Maybe they've had some amputations. Do they make any complaints to you about mobility? Like, I've been having a hard time ambulating. I have a pain in this right hip, or I'm having some back pain. Do they complain of tenderness or stiffness? Do they get cramps when they walk? Based upon what they tell you, are you seeing any swelling in those areas? Do you see any redness or heat, signs of infections, or some kind of inflammatory responses going on? So you're going to want to inspect. You're going to look at the size and the contour of the joints. So you know what a normal joint looks like. You can see the first 2 fingers here. This is very common. You see this with arthritis. It's very common to get that in all of the joints, but you can tell by looking at that that's not normal. You would also want to compare it to the other hand, right? We're always checking that symmetry. Is it the same way on the left that it is on the right? You are going to observe and compare both sides of the body. So you're going to be looking at the legs and comparing both of the legs. You're going to compare both of the arms, both of the hips. You're always comparing. You want to make sure that you're going to check their range of motion and their muscle strength. You're going to make sure that it's equal on both sides. You would get a height when they first come in. It would be used as a measurement for comparison over time in your primary care office. Their posture, you want to look at their posture. So how are they sitting? Are they hunched over? Do they have some kind of kyphosis? We'll talk about that. Are they maybe leaning off to one side? Maybe they have some kind of scoliosis. Are they able to stand up tall with their head erect and both of their shoulders, high? And are their hips equal? Do they have any kind of foot drop? Lordosis is an increased lumbar curvature. We're going to see this in a couple more slides down. And then that kyphosis is that hunchback or that exaggeration of a posterior curvature of your spine. Let's see. So when you're palpating, you're going to be, you can palpate the skin, right? Checking for turgor. You can try to feel their muscles. Are they stiff? Are they contracted? Any kind of bony areas, you're going to feel in between those joint capsules to see if the patient has any pain. Some patients that have gout, usually it's in their feet, but sometimes I see it in their hands, will be very, very painful if you touch their hands. They'll complain that and sometimes they will be hot. People that have rheumatoid arthritis and different arthritis and they're having a pretty bad time, they'll be warm and red and swollen. That's pretty common to see. And then you want to check their range of motion. Do they have full range of motion or do they have a limited range of motion? Maybe it's limited because they just had a surgery, or maybe it's limited because they're contracted, or maybe it's just been limited for a long time now and that's their new normal. So are they actively going through range of motion? Can they sit there and move their arms through all the parts of range of motion, or do you have to assist them, or do you have to completely do it for them? So if it's assistive, obviously it's just that we're assisting them. If it's passive, we are the healthcare provider are doing it completely ourselves. You want to test their neck, their thoracic and their lumbar spine, their shoulders. Just making sure they can bend all those joints, that they can flex and move. Make sure they're not having any pain with range of motion. So when we test for muscle strength, this is what we document on every day on our patients. So we always want to give it a number on a scale of 1 to 5, and we do the upper extremities and the lower extremities. So it goes, you get a specific point for each thing that you're looking at. So if they don't have any muscle contraction at all and no movement, say they're completely paralyzed or they're vented on a machine, that's going to be a 0 out of 5. That's how we'd report it. And that's how you tell it in report. Their upper extremity muscle strength is 1 out of 5, lower extremity is 3 out of 5. If they just have a little tiny bit of muscle contraction, it's a 1. So if they have movement, but it's not against gravity. So against gravity is when you can hold it up and then it'll stay, right? It'll stay and it won't just fall back down. If it falls back down, then that's a problem. If you have movement against resistance, we say that so we will ask patients to put their feet up against our hands. And if we push on them and they can push back, then that is movement against resistance. If you can pull their hand up and they can hold it out, that is movement against gravity. So based upon what your patient could do, that's the correlating number that you would choose. And that's how you would document it in this system. So now we're going to talk about edema. Talked about this a little earlier. So this pitting edema, there's pitting edema and non-pitting edema. So you can be very swollen in your legs or your sacral area or your arms. And when you push down, it doesn't pit at all. It doesn't leave any kind of indentation. That's non-pitting edema. Pitting edema leaves an indentation. You can have +1, which is mild. So if you look down here on the thing, you can see the person where the hand's going down for +1, it's just barely pushing down. +2 goes down deeper, +3 goes down even deeper, and +4 goes really down a lot lower. And it takes a long time for it lasts, that indentation stays for a while, and that means you're very, very swollen. You're retaining fluid. So now we want to look at their gait. Oh, no, we missed a question. Sorry. Which of the following assessments would be considered an abnormal finding during a skin assessment? No clubbing noted, brisk capillary refill, 3+ pitting edema in the feet bilaterally, or numerous light brown macules less than 3 millimeters in size located on the nose and cheeks.
See,
Yep, you got it. That's the abnormal finding. Very good. All right, so you would want to look at their gait as well. So you can do something called a head to toe balance. That's where they put one foot in front of the other and they walk in the room. You can do it in the hallway. You can see if they lose their balance. And then we do something called the Romberg test, where we ask them to stand straight. They close their eyes and they put their arms out. And when they do that, if they start to lose their balance, then it is a positive sign. They have something going on in the neurological system. So our neural regulation is the ability to think, to learn, to be able to reason, to perceive, and to remember. Cognition is the processes by which the nervous system activates, coordinates, and controls the functions of our body. So when we are assessing their level of consciousness, we are looking, are they alert? So when you walk in the room, are they sitting there with their eyes open? Or when you call their name, do they open their eyes and respond? Do they look at you and do they respond appropriately? Do they acknowledge you? Are they lethargic? Are they drowsy, but their eyes open when you call their name? And they respond to questions, but they fall asleep? Are they obtunded? So they're very difficult to arouse. They need you to shout loudly at them or shake them or do like that sternal rub on the chest. If you walk in and your patient is very difficult to arouse and he's not responding to you, you should be doing a sternal rub, rubbing them on that chest very aggressively and hard, not very slowly and not very easily. That's not going to do anything. You need to try and wake these patients up. That's how you can tell what's going on with them, or if they need more of an intervention. So obtunded would be that they're difficult to arouse, but they do open their eyes and look at you. They could be confused and they respond very slowly. This could be the patient maybe just coming out of anesthesia, or this could be the patient that had a stroke and has a lot of neurological deficits. And then a stupor, which means they only arouse from sleep after very painful stimuli. And then a coma, which means that they're completely unarousable and they don't respond to any type of stimuli at all. So when we look at our patient's level of consciousness, when we're doing that snapshot picture at our shift change, or when we're getting that bedside report, this is one of the things we're looking at. Are they awake? Are they half hanging off the bed because they're lethargic? Are they, completely comatose? They're not responding to you at all. And then how we report it and document it is they are alert and oriented ×4. That's the ideal. That's what we want. So we want them to be alert and oriented to their self. So that's person. They know who they are. We want them to be oriented to place, which is where they are in the hospital. We want them to be oriented to time, and then we want them to have cognitive ability. So if they meet all that criteria, we say they're alert and oriented ×4. If they only know their name and the place where they are, well, they're alert and oriented ×2. And if they only know themselves, alert and oriented ×1. We want to be able to tell if they're disoriented. So if they're saying strange things like, can you bring me back to my bedroom? This isn't my bedroom. Or can you go over in the kitchen and get me that? Or why did you put me down in the basement? Those comments would signal to you that your patient is disoriented. It is important that we assess our patient's memory. We want to look at their long-term memory and their short-term memory. So what did you have for lunch? If they can tell you that, their short-term memory is pretty good. When was your last doctor appointment? So there you're looking at that longer-term memory. Older patients might not be able to recall that. And then you want to look at their attention span. So can they really focus on you? Can they attend to all the questions that you're asking? Do they know what's happening? Or are they just changing? Are they distracted, looking at something else, thinking about something else? In the ICU, we do something called the Glasgow Coma Scale. And this is, we give them a number for each feature and their responses. And their total score is based out of 15. It was a tool. It was designed back in 1974, so it's been around a long time. And it's a tool that assesses for the level of consciousness with people who have acute issues or traumatic brain injuries. So if they have a severe, the lower the score, the worse it is. So severe is, we call it a GCS. We don't say that whole name in the nursing field. We just say, if you say GCS, they know what you're talking about. If a score from 3 to 8 is pretty severe, not looking good. Moderate is 9 to 12. Mild is 13 to 15. But there are certain things you have to take into accountability when you're doing this. Are there any pre-existing things that we need to know? Did they have a stroke? If they have a stroke, depending on whatever their deficits are, that might be a lower score might be normal for them because that is how they are now. Do they have hearing loss? Do they have any kind of speech impediment, which is not really giving you an accurate assessment? Do they have language issues or cultural differences? Any psychological issues, anything that's going to impede you really being able to assess this accurately. Age has something to do with it, things like that. So you guys can do this on your own later. You can just practice this Glasgow Coma Scale. You can read this and then, or you guys want to do it real quick. We're almost done. We can do it. So the nurse walks into the patient's room, but the patient's eyes are closed. Let me pull mine up so I can see it. So the patient's eyes are closed. So let's see, the nurse says hello to the patient opens his eyes. The nurse assesses the patient's orientation and the patient is confused to place and time. The patient is able to follow directions and move his body independently. So let's just look at the first part. So the patient's eyes are closed, but when the nurse says hi, the patient opens their eyes. So eye opening to speech, right? What number would they get?
3.
3. So now we're going to look at their verbal responses. So the nurse assesses the patient's orientation and the patient is confused to place and time.
4.
Yep. And then the patient is able to follow directions and move the body independently. What are we going to give them?
6.
Right. So what should their score be?
13.
13.
You got it. Very good. A nurse is assessing the level of consciousness of a patient who sustained a head injury in a motor vehicle accident. The nurse notes that the patient appears drowsy most of the time, but makes spontaneous movement. The nurse is able to wake the patient by gently shaking him and calling his name. What level of consciousness would the nurse document for this patient? Is he awake and alert? Is he lethargic? Is he stuporous? Or is he comatose?
C. Sputterous.
Any other answers?
B.
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 So stupor was, the definition of that was arouses from sleep only after painful stimuli. Lethargic is drowsy, but opens the eyes and looks at you, responds to questions, and then falls back asleep. So this patient is going to be lethargic. All right. This we already looked at. I don't know why this slide is here again. I meant to delete that. This is the...
No, you added that slide.
We didn't look
You
at this.
added that one. We did, but you added it up at the top.
Oh, that's right. That's why. Okay. Gotcha. So This is the pen I was telling you about. This is exactly what my pen looks like. It shows you, see the little circles on there? It shows you that's the millimeter. So you would look at your patient's pupil and then look at the side of your pen and just try and guesstimate as much as you can what size your patient's pupil is, and then correlate it with the size on here. And that's the number you give it. Most people are around a 3 or a 4, but there can be differences. So if you had a patient that came in and they were on a lot of drugs, you're probably going to see a 2. And then if you have a patient who has a major brain injury and maybe they're going to be brain dead, you would see that big one up at the top. I can't even read that number. I don't even know what that number says. So accommodation, just going over this again, this is when near vision is when the pupils constrict and the eyes converge, so your eyes cross. And then far vision is when the pupils dilate. I think that should have been further up. I don't know how they got down there. So psychosocial integrity, this is the ability of our patients' families and groups to meet the emotional, behavioral, and social demands of life. So we can do what we call an MSE, which is a mental status examination, which is part of your clinical assessment. If you think that they, this helps you look at the psychosocial. So when you do this MSE, I think there's an example of it in your book. It looks at physical aspects such as your patient's appearance. So you would look at their age, you would look at their height and their weight. How do they come into the office? How do they look? Are they disheveled? Are they groomed? Just look, they haven't had a bath in a week. These are important things that can tell you how your patient is doing mentally. Sometimes patients that have a lot of wild, bizarre, colorful clothing, that might indicate that they are suffering from some type of mania if they're unkept. Dirty clothes, that could obviously be a sign of depression, sometimes schizophrenia. If a patient looks a lot older than they really are, like if you look at him and you think he's 70 and he's really 42, well, that means that he probably has a lot of chronic health issues and he doesn't take care of himself. Some observations during your physical assessment can give you information about alcoholism and drug abuse, such as malnutrition. So alcoholics suffer a great deal with malnutrition because they may eat. Sometimes they drink and they fall asleep or they pass out and they don't eat. That's one problem. The other issue is that their body can't absorb the vitamins and the nutrients from the food that they do take in because the liver's not working right. So they have a lot of nutritional deficits. They have people that do drugs have a lot of issues with their teeth. Some people who inhale things like inhale dusters and chemicals, they can get rashes around their lips. Their lips can be red and swollen. If you look at their arms, so drug addicts who use heroin, they have a lot of scars on their arms, a lot of scars on their legs. They have track marks. So there's track marks and then there's scars. So they get track marks, and the track marks can be anywhere on their arms. Once they use their arms and they can't use them anymore, then they move to their legs. It can be their feet. It can be behind their legs, the front of their legs. They'll use their neck. Anywhere they can find a vein, they will use. And then sometimes people who use drugs that use heroin, they have something called like a heroin itch, and they scratch and scratch. So they'll have scabs on their face, they'll have scabs on their arms, scabs on their legs. And it's very common for them to come in and have cellulitis and infections because all those little areas that they scrub get infected. So really looking at their appearance and checking out their skin and putting all these pieces together is very, very important. So you have homeostasis. That is the state of dynamic equilibrium in the internal environment of the body, which is going to be maintained by those adaptive processes. So when we're looking at homeostasis assessments, we are going to look at their IV infusions. So what types of fluids are they? Do they have any fluids running right now? Are they on any fluids at all? What rate is their infusion going? These are things that you're going to want to do when you're doing that shift change and you're doing that bedside report. So you want to look and see what's going. You want to see how fast it's going, how much is left in the bag, because it's going to signal, hey, maybe I want to see this person first if they have just a little bit of stuff left in their bag. And then you want to make sure that their tubing is labeled and that their bags are labeled. So fluid bags usually in most facilities are only good for 24 hours. And you should have documentation of that on your bag. It should be dated when you hung it up and it should be dated when it expires. And the same thing with your tubing. You always want to follow your facility's policies, but usually tubing is good for about 96 hours. Unless you disconnect your patient. So if I hang up tubing on our patient and they're getting normal saline, if I never disconnect them from their IV, it's good for 96 hours. If I disconnect them a couple hours later to send them to MRI or for a test, then that tubing is only good for 24 hours. Once you disconnect it, it's good for 24 hours. So are the IV fluids and the rate that's appropriate, that rate that it's going, is it appropriate for your patient's condition? So if your patient has congestive heart failure or a history of congestive heart failure and they're getting fluids at 200 mLs an hour, that's something you probably want to think about. Did the doctor pick up that she has CHF? Something you might want to mention to them. When you're giving blood to patients, you want to be very cognitive about the amount that you're infusing the blood, especially those patients who are already sick and have respiratory issues or have volume issues, because you don't want to instill that blood too quickly and cause any kind of fluid overload. So what are some complications? So do they have infiltration from their IV? So did the IV stop working and then all the fluid is just going into the arm, into that interstitial fluid, and the arm swelling up? And now it's cool. Was it maybe they were getting potassium, something that's very caustic to the veins, and now it's not in the vein anymore and it's leaking and they have phlebitis in the arm, redness, warmth, swelling. Maybe their IV is leaking. All signals that we would want to take that IV out and go into another site. And then, of course, we're going to be balancing those I's and O's, right? We're going to document all of them, that IV fluid that we're giving them. I document every 4 hours because I like to stay on top of it. Some people do it at the end of their shift, but it has to be definitely done on your shift. And then has there been any recent weight gain or loss, which means that they're holding on to fluid, right? If they're gaining weight. Or has their weight remained the same? This is something that we're very cognitive about with our patients with CHF, because especially when they're at home, we tell them if they've had a weight loss of 1 to 3 pounds over a 3-day period, that they need to call their doctor. Something's going on. And then is there any evidence of fluid volume excess? So if your patient has fluid volume excess, they're going to have that swelling, that non-pitting or that pitting edema. And then if they have a deficit, they're going to be dehydrated. You're going to see that in their vital signs. They might be tachycardic. Their blood pressures are going to be low. So why would if they were dehydrated, why would their heart rate be tachycardic? Do you guys remember?
Because the blood volume is low?
Yes, but what's going on in the heart? Why is the heart speeding up? Why is the heart beating faster if their blood volume is low?
Trying to make up the difference. If the blood volume is low, then it needs to pump more blood to do the same job.
Exactly. Yes, exactly. This is the focus that this is where our focus is going to shift in a couple weeks when we start that next class, when we start Concepts 1. This is the kind of stuff we're going to be talking about. So I'm going to try and incorporate that with you guys anytime that I can, so that you guys feel prepared for that. So let's answer this question. Which of the following is the best indicator of fluid balance? So those serum electrolyte values are your potassium, your sodium, your magnesium, things like that. Your daily weights, your urine output, or your mucous membranes. Which one is the best indicator of fluid balance?
Urine output.
What else? We think anything
Like
else
daily
besides
weight.
C?
A.
Electrolyte.
B.
Oh,
This is a tricky question. B, the answer
other
is
question.
B.
Other question.
Hold
Which
on,
of
wait.
the following
Let's
is
wait
not
till the end,
indicated?
Martha Lynn.
Oh, okay.
Daily weights is going to be the correct
B.
answer. That is
Yeah,
the
it's
best,
B.
that is the best indicator of fluid balance is your daily weights.
Yep.
Okay. So your metabolism is the physical and chemical processes by which the body builds and maintains itself through anabolism and catabolism. Remember those words from biology? Blood glucose. So this is your diabetic patient. So does your patient have diabetes? If they do, you're going to be monitoring their blood glucose. Some patients in the outpatient setting, they have diabetes, but we control it with oral hyperglycemics, which means they just take a pill every day. Patients that have had longer uncontrolled diabetes will have, they'll have to take insulin every day. When patients come in the hospital, even if they just take oral hypoglycemics, we cannot administer them in the hospital. We have to put them on what we call sliding scale, and we have to give them insulin because the medicines that they take can interfere with certain procedures that we do. One of the medicines that you'll hear a lot about in future classes is metformin. If your patient takes metformin, which is one of the major medicines that we give for diabetes, it will interfere with contrast. If they are taking that pill and they come in and they have to have a CT and they have that contrast, the two of them together will put them into complete renal failure, completely shut down. They'll end up on dialysis. So that's why we take them off of that medicine when they come in, and then we just cover their blood sugar with insulin while they're in the hospital. So if they're diabetic, you're going to want to know what their patient's blood glucose is. You're going to want to make sure it's within the normal range. Normal range is 70 to 100, 70 to 110, depending on your facility. Do your patients have any signs of hypo or hyperglycemia? And what are the patient's blood glucose trends? You might hear a patient, you might check their blood sugar and it's 285, and they might say, oh my God, it's never that high. Why is it that high? It's usually in the 150s. What's going on? Well, you want to look and see what other medications they're getting. Patients that are getting steroids, you can always expect that their blood sugar is going to raise. Patients that are under stress, your body produces more cortisol. Cortisol raises your blood sugar level. So these are the things you want to keep in mind so that you can put your patients at ease and you can educate them. So when patients have low blood sugar, they're going to get white. You're going to see that paler. They may start to sweat. They can be very confused. They can lose consciousness completely. I've had patients that just completely fall out on me. They can be very, very groggy, very sleepy, hard to talk to. Very hungry. I think we've all probably been in that situation where we haven't eaten for a few hours and we start to feel a little shaky, we get a little clammy, we're really hungry, and we are hangry, so irritable. And then hyperglycemia, that's when their blood sugar is very high. So hypoglycemia is very low blood sugar, hyper is very high. So they're going to have that increased thirst, always, always, always thirsty. They're going to have very dry mouth. They're going to report, they might feel weak. They might complain of a headache. You can come in. They're going to have blurred vision and then frequent urination. So which of the following findings should be reported to the doctor for a client on bed rest? A patient that has palpable pedal pulses, a weight gain of 1 pound since they were admitted 7 days ago, orthostatic hypotension, or crackles heard. You guys gotta mute your things, please. Crackles heard in bases of lungs bilaterally that clear with coughing.
Orthostatic hypertension.
You got it. Why not the crackles?
Because it clears with a cough, so it's just like bronchi.
Yes. Very good. And that's it. We are done